Dr. Manuele, thank you for inviting me out to Las Vegas to come shadow your practice and interview you. You are one of a very few number of doctors that is using the new FME MARPE expander. Why are you using it? What's different about it? Can you give us a sort of matrix download on the FME?
Sure, yeah. So I mean, the FME is one type of MARPE, as you know. And so there, in my opinion, there are some advantages, potential advantages, I'll say right now, because it is untested in that we haven't had hundreds of patients go through this process. We haven't been able to look at the before and the after cone beams, but they put a lot of thought into this device, and I think that it's worth exploring a little bit further. You can see here an earlier version. So this earlier version breaks down the basic concept and how it's different from some of the other MARPEs that are being done. So you have initially what they call these anchor bodies down here, and these are basically two rigid metal bars that are fixated to the palate with the TADs. And you can have between 6, 8, or 10 TADs with the current designs available. You can see this was an earlier TAD.
But by the way, are the FME TADs different than the custom MARPE TADs or the MSE TADs?
So they are different because they have their own proprietary TAD. And the most unique thing about them is the locking mechanism of the TAD and how that secures to the anchor body. So when you look right here, you can see that the TAD goes all the way down into the anchor body. And you can see these threads here. These are for the retaining screws, but there are similar threads on the head of this TAD that actually lock it into place so that you know when this TAD is fully seated, there's only one way that it can be. And so the idea or the theory behind this is trying to overcome some of the limitations that we had with things like MSEs, and still to a certain extent with custom MARPEs, but not as much as with MSEs. Whenever you have wiggle room in the system, then there's going to be basically less expansion actually happening than at the jack screw itself. Right. And so the idea is if we can create a more rigid system that doesn't allow the TADs to bend or tip as much, then we can get more predictable and more accurate expansion. And specifically, hopefully, one day we can actually control the expansion in 3 dimensions. So instead of just putting an expansion force and having the expansion turn out however the resistance and the anchorage dictates, because that's always the equation that decides where the bones end up going, we could actually start expanding and then perhaps modify things in order to adjust the expansion in the exact way that we want it. So if the left side starts to go more forward or down, we could actually be able to adjust it in some way. Either via an extraoral type force appliance, or possibly even something, being able to adjust the FME itself. So that's kind of the direction that they're going and some of the shortcomings that they want to overcome with it.
So we have locking TADs, and you can actually see the threads in, is there a better visual of, because I think when people hear about the so-called locking TADs of FME, they don't totally understand what that means, even though it's really not that complicated of a concept.
Sure.
Can we get a better visual on that, maybe?
Yeah. So this is the. We'll blow this up as much as we need to here. These are the locking TADs. So you can see here, there's threads that go into the bone, and then you can see here, there's threads that are wider that lock into the anchor body. So these ones here, what's locking it in. You also might notice if you're an engineer type, that the threads look different. These look like they're closer than these. And so you're thinking like, well, how does that work if the threads are turning, at one speed and then it's locking into the body, but the threads are different? But these are actually dual threaded. So for every two of these threads, there's one of these threads. So when you're locking it in, it goes in at the same velocity.
Oh, it's a perfect 2-to-1 ratio.
It's a perfect 2-to-1 ratio. So that as you turn, the velocity of the TAD pulling itself into the bone with these threads is the same as the velocity of the top of the TAD being anchored or secured into the anchor body itself. And we can pull one of these things apart and take a closer look at some point if you want to see that,
Yeah, maybe we continue a little bit with some of the digital visuals and then we'll get hands-on with an FME. But this example that you just showed of some of the more intricate design properties of the FME, it gets to something we were talking about off camera yesterday about the nature of this Facegenics company and their incredible attention to detail. And by the way, full disclosure, I don't have any financial affiliation with them.
Nor do I. Yeah.
Nor do you.
Nor do I.
Right?
No, just a user.
So yeah, right. We're both just interested in having MARPE become better and have lower, less complication rates, more success.
Right.
So you were telling me that, tell me about Facegenics and how they compare to other medical manufacturing companies. And
Yeah, what's interesting is that most of the innovations within our space happen from people within our space, existing people within our space, right? There might be a lab that comes up with, a new device, a new appliance, or a doc that's working with a lab that comes up with something new. Very similar to Juan Moon coming up with the MSE, the very beginnings of all of these things. So this was interesting to me because it really wasn't anybody inside of orthodontics that was working on this. I mean, it was a couple brothers that got together and saw a problem, and part of it was their own personal story, and I don't know all of their story, but basically they saw and started to research this space, and the more they researched, the more they realized that there are a lot of shortcomings and that somebody eventually is going to do it right, and they wanted to be those somebodies. And so they started to dig through all the research and just started to design from scratch. They took what we knew about MARPE expansion as kind of a starting point, and then they grew from there. And as they continued to develop, I mean, this is at least the second version that we're on now here, and they still haven't settled on a final version yet, and that's why it's not commercially available everywhere yet. But they're doing it the right way. Every step of the way, they're getting feedback from docs who are using it. And also from the labs that they're working with. And so, it seems like they're entering this space to do it the right way. Very similar in a way to, when Invisalign entered the space. Nobody was really moving teeth with clear aligners, and, some people that were kind of outside our space said, hey, this is a big potential. And so they jumped in, and the early days of Invisalign, there was a lot of hiccups. And that's where we're at now with MARPE in general. There's still things that need to be overcome. But the more we invest our time and energy into learning and overcoming these things, the more the more predictable expansion is beginning to come.
Right. So can you tell us a little bit more about how this design helps solve some of the recurring problems that were happening with other MARPE systems like MSE or custom MARPEs?
For sure.
From various labs?
Yeah, I'll start with kind of one of the bigger things in my opinion. So one of the challenges of skeletal expansion is that when you expand, there is a direction that the bones are going to move. Now you hope that those bones move exactly symmetrical and from a top-down point, exactly horizontal. You want to expand as perfectly even as you possibly can. But the expansion is never perfectly even. There's always more resistance on one side versus the other, depending on the density of the bone in one location versus another location. There's a lot of factors that determine where those bones are actually going to end up. And so when we go way back to the original, MSE version 1, there was basically just 4 TADs and a screw mechanism. And there wasn't really a lot controlling where those forces went. And so what could happen is, one side could break or fracture and start to move in an unwanted direction. Or if the screw wasn't set perfectly, this side of the jaw could move more than that side of the jaw. And these are still challenges that we are overcoming with all the current MARPE systems on the market. With this, the idea was let's design it from the very beginning in a very precise way so that the forces that we're applying to the bone are the most controlled possible. And so they have 6, 8, or 10 TADs that are designed off the cone beam, the actual skull itself, using skeletal landmarks. And we can pull some of those up if you want to see those.
Definitely. And how does that differ from the custom TAD placement that can happen with a custom MARPE?
Yeah, so with a custom MARPE, the benefit of the custom MARPE is that the TADs can go wherever you want. So you can literally find the best bone on the patient, and that's where you can place the TAD. So that's actually an advantage of custom MARPE. But right now, they're not using the same cone beam landmarks to set the actual screw. And the actual screw in the middle is going to be what determines the force that are applied to those TADs. And so it's really setting that center screw correctly from a vertical standpoint, from a slanted standpoint. And we'll go through a case later where, it was set a little bit off, and you can see the effect that actually has. It makes a big, big difference. And this is something new to orthodontics as a whole, because we've never been able to expand adults. We expand kids, and kids are very resilient. When you expand, if the screw's a little bit off, they still tend to expand relatively symmetrically. And when you're attached only to the teeth, it tends to even itself out because the teeth can move. Now that we're anchored to the bone and we're expanding adults, we're realizing how big of a deal this can be and how important it is that the forces that we're applying to that jaw are as ideal as possible.
Right. In what you're basically explaining in more detail is the asymmetry problems and the leveling issues and the cant formations that we've seen in some MARPE cases, some worse than others.
All of those things.
And to your mind, is that the biggest problem that MARPE has, is the asymmetry problem?
I would say that's the most challenging complication to overcome. And sometimes you can't overcome it, right? So if you have an unwanted fracture somewhere, that's a fracture.
Tell us about some of the places where those fractures might occur commonly.
Yeah. So I mean, commonly, probably the most common one is going to be your frontal maxillary suture up here. And so that's why when we
right where the orbital meets the top
nasal
of the
bone
nose.
meets maxilla meets frontal bone here, basically right here between between your eyebrows. And that's the one we always try to educate patients about, like, hey, pressure around this area, and the jaws, that's all normal. Pressure in the cheeks, normal. If you're feeling a lot of pressure or pain here, like, let us know. And that's why if we have a fracture there, we want to know about it as quickly as possible, because if you don't know about it and you keep turning, then essentially from the orbit down, this whole side of the face will expand down and forward more than the other side. It creates a facial asymmetry. I know there's some cases going around Reddit that show that pretty well.
Definitely, yeah. There's some so bad that orthodontic surgery could be needed to correct them.
Well, and not even just orthodontic surgery, because our normal orthodontic surgery, Lefort 1, I mean, the cuts are down here.
True.
But this is affecting structures even higher than that. So, it could be, is it worth the risk to go in there and try to move the orbit back? Like, maybe, maybe not. So you might still be working with a compromised result. I mean, this is the far end of extreme of what can happen. And by and large, this is 100% avoidable. Making sure that you're having good follow-up with your doctor, that, they're keeping an eye on the expansion and making sure you're following their instructions. But again, if you go rogue and you turn your expander 100 times, I mean, that's one thing that could happen.
On that note, tell me about the software that you use to monitor patients that are going through a MARPE process.
Yeah, so personally, there's two big ones out there, dental monitoring and Grin. And I personally chose Grin to use for my monitoring, but it allows them to take a scan of their teeth every single week. And so while they're in that active expansion process, I'm able to see exactly what's happening, how the teeth are responding, how the bones are responding, and probably most importantly, how the face is changing and shaping. And so in addition to the scans that they'll take of their teeth, they'll also take a photo of their smile so that we can see how things are developing.
Right. And you can see if that leveling problem that can happen with a frontomaxillary break, it's very obvious.
That's
in
correct.
A lot of cases. And then you nip it in the bud. You would turn something like that back?
Yeah, in general, if you have an actual fracture, you don't want to keep turning, because the more you turn, the further away it's going to get and the worse it's going to look.
Right.
So at that point, you're going to back turn as much as you can to restore symmetry, right? So until facial symmetry and the jaw symmetry, and then you'll reevaluate and see, where are we? How much expansion did we get? Do we need more? Can we take it from here? Do we need surgery? Like, what do we need to do?
Can we go to some more visuals to demonstrate the point that you're making about Facegenics and the FME carefully planning the orientation of the jack screw of the expander?
Yeah, let's look at some things here. So first off, so this is an example of some of the landmarks that are used. You can see here, this is from a workup from one of the FME cases that we're doing. And so you can see they're looking at, they're looking at the cheekbones, they're looking at the symmetry between the lower jaw, the upper jaw, and the nose up here. And they're using these landmarks to help identify where, horizontally and vertically, all three planes of space, we want to dial that in as good as possible. Here's some other examples here. This shows how the TADs are planned. So what we're looking at here is a cross section of the top jaw. You can see the front teeth on the top and the bottom here. So these are fitting, forward. So we're looking back. This is the jaw here. And you can see this is the outline of the anchor bodies. You can see here, actually, if you blow into your question earlier, you can see how those threads lock into the anchor body there.
Oh, wow. That's a great visual of the locking TADs.
Yeah. And then this is the bone. So you want to traverse through the bone, and you want to have bi-cortical engagement. So you want to go through the second cortex here. And so that's what that's showing there.
Why is there an extension of the TADs, that second outline that goes much deeper into the nose?
So that is just a visualization tool. So this is kind of the range of TADs that they can use. So there's never going to be a TAD that's placed that long. But basically the library and the way that they use it, they have different lengths of TADs that they can select. And so this kind of shows basically all the options. So if they were in an area that they needed, a deeper TAD, they could do that.
Got it.
Yeah.
Okay, fantastic.
In this case here, you can see that all three of these TADs are the same depth. And that was all that was needed in order to get bi-cortical engagement here.
Can you point out the bi-cortical engagement? That's another concept that people have a hard time visualizing.
Sure. So this wider bone here is cortex, and you can see this wider bone here is cortex. Pretty much all of your bones have, cortex on the outside, which is denser bone. All right. So that's like the strong bone. And then in the middle is the cancellous bone, and that is a little bit softer and easier to manipulate and move through. So if you put a TAD in and you don't get bi-cortical engagement, so let's say you put it in and it only goes to like here, it doesn't go through this second cortex. Well, then what happens is it's very similar to just, there's basically wiggle room there. So the TAD itself can actually start to move within this spongy bone in the middle, and it's not as predictable. So when you engage both this cortex here, this white cortex here, and this cortex here, it creates more of a lock around that TAD so that as you're pushing, there's less tipping, there's less dragging, and it's more predictable. Your anchorage is better.
Wow, so bi-cortical engagement is not just about depth, it's about really securing the high end of the TAD and locking it in place in that second cortical layer.
That's exactly correct. So the stabilization of the TADs goes way, way up when you're able to do that. Now, some areas you may not be able to do that. For instance, if you're going from here and trying to get, bi-cortical engagement all the way to here or something like that, it may be too long. And so in that case, you're going to engage as much bone as you can. But typically from about the first premolar back, you're always going to be getting bi-cortical engagement. Because the bone is thin enough to go through it with the TAD.
Got it. Yeah, could we get to the visual about the, continue explaining the landmarks that are used to plan the appliance?
Sure. Yeah. So this is another example here. You can see this is taken all the way up to the base of the zygoma here. So there's a lot of different angles. This is taken from the skeleton as well. So you can see where the facial midline is compared to the maxillary
These lines have significance, right?
That's correct.
These axes that we're seeing?
That's correct.
I don't get it, really. I know they're trying to plot something, but what are those lines telling us?
Yeah, well, so basically what they're telling us is where if your head is in, the right spot, looking forward, straight, symmetrical, the way that most people look at you, what are those axes, right? Because the jaw and the teeth sometimes tell a different story, right? So you may be symmetrical here, but then down here you're not. So when you're expanding, if you're considering, well, maybe we can make that a little bit better. So let's say, the top of your jaw is symmetrical, like from here up, it's good, but the bottom half is slanted to the side. It's completely off to the side. Well, when you go to expand, if you could do something that levels that out, meaning change the forces. So instead of just placing it on the jaw the way the jaw is crooked this way, change the force so that the screw is going this way. Then you can actually start to move this side up more, this side down more, and start to level the jaw as it's expanding. So that's the direction that they're going. They want to be able to do that predictably. That's
what you meant when you said three-dimensional expansion.
Correct. You want to make sure that in all three dimensions, it's controlled. And right now, it's fairly well controlled, but again, we can't look at every single spot where the maxilla attaches to the rest of the skull and know exactly how much resistance all of those points are going to have.
How does the approach that they take differ from Dr. Lipkin's sort of rule of thumb, which is to make the expander parallel to the bite plane, or rather than to the palate itself? Because sometimes they differ, and if you always follow the palate, sometimes you create an asymmetry or a cant that way.
Yeah. Well, I'll back up a little bit. So one of the challenges, or one of the things that is fairly well known in this space, is that if you have an existing cant,
yes,
it gets better or worse with MARPE.
Right.
Generally worse, right?
Right.
Well, the reason for that is as you're expanding, your two things are happening. Jaw's coming down and forward. And if there's any asymmetry, the actual forces of the appliance, if it's placed relative to where the palate is and the occlusal plane, if both are slanted, you're just, not only is it going to, even if you expand it perfectly symmetrical, it's going to look worse because it's coming down. But if you get at all asymmetric expansion, the jack screw itself in the middle is pointed down on this side, up on this side. It's going to make it even worse. And so if the jaw is slanted like this, the idea behind FME is like, let's get the screw put in like this. Or maybe even like this, and try to correct it as we go. So this is the part where, I mean, I haven't seen cases where we've corrected 4 millimeter vertical discrepancies by doing this, but this is the direction that they want to go. And so you have to decide where you're going to place it. A good rule of thumb, just to try to get even expansion, meaning to get the right side to expand as much as the left side, even if it's slanted, is to do exactly like Dr. Lipkin says, like put it in, with the occlusal plane, with the skeletal plane, just kind of make it even, and then you'll get even expansion. So one side's not expanding more than the other. And then you can deal with the slant in other ways. You can put some TADs on the side, move that whole side up, or use rubber bands to bring the other side down.
Right.
So that's kind of the workarounds now. But if we could predict and get the skeletal expansion controlled to exactly how we want it as we're going and be able to modify that as the expansion is happening, that would be very significant.
Totally. Are there more visuals that we can look at here?
Yeah, let's take a peek. So this shows the appliance placement design. So again, this is significantly thicker than the original designs were because again, it was discovered that we need more strength of the appliance in order to maintain the symmetry of expansion. So this is the entire FME placed. You can see there is a gap here. And in this case, this is a symmetrical case. So you see that this gap is even, essentially even from the right side to the left side. But if there were a slant of the entire palette, say the entire palette were slanted this way, then you would see that this would be longer here and shorter here if this were placed horizontal to the face.
That gap that exists between the expander and the palate, couldn't that itself be problematic in some ways?
So the further away the screw force is from the anchorage, which is the bone, yes, the more problematic it is.
Right.
From a mechanical standpoint, meaning that you're going to put more stress on the TADs in the system, and it's a simple, it's a simple lever mechanics, right? If you use a pry bar, you can put a lot more force down there than if you're trying to, to hold the thing up from the middle or whatever.
Right.
And so same idea applies. The closer this screw is to the anchorage, which is where the bone is, the more force you're going to be able to apply to the jaw without things breaking, bending, or having problems. And so certainly that's a shortcoming. So the idea behind FME is, well, let's make this as bulky as we need to accomplish the goals that we have with asymmetrical expansion, but also be able to have it be sustainable without breaking and fracturing and having complications.
So those gaps are intentional then?
Those gaps are intentional, that's correct. Additionally, it does create a space where the patient can clean under. Or you can think about it the other way, it can create a space that's hard to clean under. And so, yes, they are intentional though, it's designed that way. And, time will tell if we can get this dialed, or if they can get this dialed in enough. And I say we because, any company that's willing to put this much time and effort into helping make our lives easier and help get better results for our patients, that's a company that I want to stand behind.
Totally. What other visuals can we look at to understand the FME design better?
So here's some additional landmarks you can see here. This is the nasal cavity in the bone. So they're looking at the different areas of thickness of bone that we have here. Again, there's our cortex here and our cortex here. This little blue outline is the soft tissue. So you can see where that is. That's going to become important when they design the guide. And this also shows at the different depths where these TADs are placed and what that looks like from a right to left standpoint. This is looking up at the jaw. So you can see here where the skeletal suture is versus the bony suture versus the facial midline. So you can see here that it's not lined up exactly where the palate suture would be. Yes, it's between the palatal suture, which is in the middle here, but it's actually aligned to the skeletal landmarks, which is these crosshairs that you can see here. And then they also will give you the different lengths of TADs that you need to. So anything in range from 11.5, and I think they go all the way up into the 20 millimeters as far as the TADs that you can have, and then the number of the TADs. This is going to help you line everything up when you're actually delivering the FME to be able to make sure that the right TADs go in the right places. Those are all color coded as well.
And the surgical guide, that is a very unique feature of the FME.
This is the surgical guide here, and there's actually two guides. So the first guide is simply for piloting. And this is unique because, when an MSEs first came out, and even when custom MARPEs first came out, and even now, there are still practitioners who don't subscribe to the idea of piloting. They just don't feel like it's necessary.
What is piloting?
Yeah, so piloting. So basically what piloting is it's using some type of drill in order to create a hole within the cortical bone, that first cortical plate, the hard plate. So, I mean, you're looking at a skull like this, all the things that you see are cortical bone. Mm-hmm. So it basically punctures through the cortical bone in that area. The screws that the TADs are actually self-tapping screws. So they are designed to be able to puncture through that cortex. But just like a self-tapping screw, like if you're using a sheet metal screw, for instance, you know, if you're pushing straight down on the sheet metal, it works perfect every time. It just goes straight in. But if it's at an angle, one way or the other, it might slip a little bit before it engages. It might go, you know, the other way. And there's some wiggle room as far as where that may actually lock into that cortical bone. And the challenge that can cause is two things. So one is it can cause undue stress on the appliance. It can cause the screws to work against each other. So one slips this way, one slips that way, and then you're trying to tighten these things down in, and you can't because the screws are actually binding in the lumens of the appliance. But for me, the most important thing is that there's always going to be, with the exception of FME, again, this was something they overcome, but if you just have a lumen or a sleeve going around the TAD, there's always going to be some degree of wiggle room. It can never be 100% perfect fit because it would bind. You wouldn't be able to actually deliver it. So there's always a little wiggle room between the sleeve and the TAD that's going inside the metal sleeve. And so if those screws go a little bit off, well, now your anchorage is different than you planned to a small degree. Now, is that significant? Like, time will tell. But from my standpoint, it's a lot easier and more predictable to pilot first, which means you take a small drill, and there's different piloting drills, and you puncture that area. And with FME specifically, the guide is designed to fit as ideally as possible. And it is a plastic guide, plastic type guide, 3D printed guide. And so basically that piloting drill can only go straight up and down in one specific area. And so you go and you pilot, punctures the hole. Then there's a second piloting drill, which takes that hole and moves it just a little bit further down into that spongy bone so that when the TAD goes in, it has a nice site that is already ready to receive that TAD in the exact angulation that was planned.
So piloting is built into the design of the FME. They don't even give you a choice.
That's correct. It's part of the process. I mean, so could you try to place the TADs without piloting? You could try to, but I don't know why anybody would do that.
And in the case of the FME, the TADs probably just wouldn't lock because of the margin of error.
That's correct. That margin of error, when you got down to the point where you're actually trying to lock the TAD in, my guess is that it would be very difficult to get that to go, and a lot of times it probably wouldn't.
Yeah, this surgical guide reminds me of like orthodontic surgical guides where specifically with the custom plates, they have before you put the actual plate on, there's a guide plate that they use to pilot through where the actual plate holes are going to later become and the screws are going to go in. So it looks like they poached some ideas from other orthopedic surgery.
For sure. Yeah, I mean, 3D planning of surgery has been around for a long, long time. And so they just basically moved it into this space.
Yeah, which is a very welcome innovation.
I agree. It does also, from a clinician standpoint, I wasn't sure how long it would take me to deliver this compared to like a custom MARPE because there are more steps involved. But my first FME that I delivered actually took less time than it took me to deliver the MARPE we did yesterday. So
wow.
Yeah, no, it does when you have that level of precision, it does make it fairly predictable. And so it's just from one to the next, to the next, to the next, to the next, to the next. It just limits the amount of error that you can have.
Yeah, and when I reflect on it now, it is kind of like the custom plates, like you talk about jaw surgery custom plates that Dr. Alfie, for example, is known for. Other surgeons do it too, but this is like the analog of that to MARPE.
Correct.
Great. Are there other visuals we can look at to
see what else we have?
See the piloting process or
the
installation process?
This shows a little bit more. Again, you can see that there's an actual space. This is a 10 TAD FME. So again, this space was needed due to the depth of the palate and also due to the alignment. With the way that was aligned, these TADs you can see sometimes have to be longer. So there is a portion that's hanging out of the bottom of the FME there. Mm-hmm. So this shows the retention screws. So this is the top part of the MARPE, and we can go back to here. So right now what's happening, and this is again the newer design than is shown here, but these screws are screwing this part onto this part. Okay, so this part's already been installed with the custom guide. Now we are taking and we're screwing the actual screw part of the FME to these anchor bodies here. And so that's what you're seeing here. So in the middle, and we can zoom up on this later on the type it on, so it'll be easier to see. This middle portion is the actual screw itself. And now we're using these retaining screws to connect the two. There are 3 TADs that are underneath this area here. So essentially these ones here, they're hidden so you can't see them. This is locking down. So in addition to the TADs themselves thread locking into the anchor bodies here, we have this rigid piece of metal, this whole expander screw apparatus that is locking down on top of that. So even if this were to try and bend or strip or something or unscrew, this is going to prevent that from happening because it's rigidly fixated on top of those TADs.
Wow.
Okay. And so that just kind of shows this is some of the driver, how it works, and everything is, again, all the details are accounted for. So it's very, very specific in the amount.
All of these tools proprietary to FME?
They are. Yeah. So
it comes as a whole kit?
It comes as a whole kit. So everything, you send them the images, you send them what you want to accomplish, your treatment plan, and they're going to design everything, and then they're going to send it back to you and say, hey, this is what we're seeing. And this is where we think that the screw should be. And then you can decide, hey, is that where I want it? Is that the amount of bone anchorage? Do we need to move it forward or backward? But they design the case for you. And then once you approve it, everything is sent to you. So you have the custom guided trays. You have all of the TADs specific for that case. You have the drivers that are used to place the TADs and the anchor bodies in. And the other cool feature, and this is not unique to FME, although I believe they were the first ones to think of it, is when you expand, let's say you get to the end of this screw and you still need more expansion. Well, you can take this body out and screw in a different screw body and continue to expand. Right. And so for very severe cases, it does allow for more flexibility, the more expansion that you need.
And what would that workflow look like? You take a new scan, send it to them, and they fit the second piece?
I don't believe so. I believe what they would do is they would just have different measurements of length. And again, I haven't done this with them yet. I don't even know if they can do it yet, but I know that that was the design process. So if they're doing it, what would happen is they would have, let's say, a 6mm screw where, hey, we're going to send you a new one, but it's already, basically as if it were 6mm opened. And then you would just place that in there. And if it was a little bit off one way or the other, you could open it or close it to get it to fit.
Is that something that occurs often, to have multiple expanders on one patient just to get more magnitude of expansion?
So not often. There are pretty severe cases that could justify or need that. Most of the time when a second expander is needed, it's because something happened to the first expander and you didn't get as much expansion as you needed due to some type of failure of the expander, whether it's the TADs or something.
Right.
Yeah.
And in that case, when you have to ditch one MARPE for a second one because the first one failed, do you need to take a multi-month break between to let the TAD holes heal so that you can replace screws in that bone?
So, early on when we were using, MSE4s to try and expand, adult males and females, this was much more common because even with good anchorage, before we were doing piezotomes or cysts like that, you had a lot of resistance and sometimes you just wouldn't overcome it. So you might get to the point where you're tapped out of the expander, you've turned it, up to 12mm, but yet the bone itself hasn't moved very much, but maybe it has, maybe it's moved a little bit. Maybe you have a small diastema. My thinking is I want to anchor to new bone and I want to keep turning as quickly as possible because I don't want to give that suture time to, redevelop or form or start to harden before the expansion is done. So, knock on wood, I haven't had to do a second screw in a long time, but, when we had to do them before, what I would do is I would actually have them design the appliance itself off of the original teeth model before anything was placed so that they can design new 3D printed bands. And then I send them an updated model of where those teeth currently are, and they fabricate a new MARPE using different holes, basically. So instead of the ones that were used originally, you'll go forward a couple millimeters, and then that way you can, the same day, take out the old MARPE or MSE or whatever it was, and place the new one. You only have to get the patient numb once, and then you can continue expanding, as quickly as possible.
Now, you mentioned earlier choosing between forward or backward placement of the appliance. This is obviously a huge matter of controversy in the MARPE world, where you have one school of thought that any forward placement of the appliance is catastrophic. It's going to lead to this conical expansion that doesn't confer any nasal airway benefit, and yet MARPEs have become more forwardly placed because the bone is thicker up front. You're more likely to get an actual split. What are your thoughts on that sort of debate? And what does Facegenics think about that? And how do they factor the AP into their appliance design?
For sure. Yeah, I won't speak for them, but I'll give you an idea of how I think about this. So when you're talking about expansion and what's going to happen with the bones, it's always a formula of what anchorage do you have and where's the resistance, right? So the anchorage is very similar. You have access to TADs, right? So that's hooked to the bone, and you have access to teeth. If you do a custom MARPE, you can incorporate teeth. The teeth have roots, the roots hook to the bone. So those are your anchorage system. The worse or the less anchorage you have from your TADs, if you're attached to the teeth, the more force is going to be applied to them. So when I think about expansion, the number one most important thing for me is to get sufficient, if not extra anchorage. It's almost like you can never have too much anchorage. So I do err on the side of engaging as much bone as possible and really having more TADs versus less TADs. There is a level of predictability that comes with good anchorage that you lose when you don't have good anchorage. And so from my standpoint, if the anchorage is better in the front, then I'm absolutely going to engage that bone. And oftentimes it is. The bone is thicker. You can use longer TADs. But that doesn't detract from the importance of the posterior anchorage as well. So ideally, you're engaging all of those bones, in my opinion. And if anything, that may be one shortcoming of the FME, because at least as it's in its current state, it is a fixed appliance. So there's 3 versions of it, but the TADs only come out of the appliance in one way, and the length of that body is fixed. And so it's going to go in one place. It can be more forward, it can be more back. The FME cases that I have going are kind of in the middle, if not maybe a little bit more toward the back. So the question is that anchorage going to be sufficient due to all the other technology we already talked about to overcome the resistance forces in a predictable way?
Who decides whether the appliance is placed more forward or more back? Is that you, or is
Ultimately,
that
it's the doctor. Ultimately, it's the doctor. Now, Facegenics is going to give you their recommendations, right? So this is something that they've looked into a lot, and they're looking at the bone in 3 dimensions, and they have their whole workup that they do. But at the end of the day, they're going to send it back to you, the doctor, to make the final decision and say, hey, is this where I want it, or do you want to move it for some reason?
Right. And do you agree with the criticism of interiorly placed MARPEs that they always lead to cone-shaped expansions that are not as parallel and that have more expansion up front toward the front of the mouth, where you get a bigger diastema, a bigger opening at the front of the nose, but not as much expansion in the back?
Yeah.
Or is that a goblin that is overplayed in terms of critiques of MARPE?
Well, probably yes and yes. So I do think it's a goblin that's overplayed, meaning that, some people place a lot of importance thinking like, oh, well, if you just don't do this, then this is never going to happen to you. And I don't believe that. Like I say, it's always a function of the resistance. So depending on the patient's bone density, where their maxilla connects to their zygoma, there's a lot of factors at play that are going to determine how parallel your expansion is. But I also do believe that the more forward you place your anchorage, specifically if you don't have as much anchorage in the back, or you don't reduce the resistance in that back area, meaning you want the midline palate to split. So, whether it's a piezotomy osteotomy or whatever you might want to do in order to get that, if you're reducing the resistance in the back, as soon as the 2 halves of the maxilla separate, then everything else has to bend. And so at that point, you have control to some extent, and you're not worried about the anterior posterior expansion anymore because you've gotten a clean split down the middle. Mm-hmm. Okay. Now, the argument comes up, well, what about the pterygoid plates? And, there's all these different things. And long story short, I've never seen convincing research that shows me, hey, if you do it this exact way, you're going to get parallel expansion every time. And I've seen a number of cases, both my own and other docs, who, they have posterior anchorage and they got, more triangular expansion, and they had anterior anchorage and they got more parallel expansion. So I'm not convinced at this point that it's as hard and fast as some people make it seem.
Mm-hmm. Yeah. What else do we need to know about FME? Do you have any other visuals we can look at to better understand this appliance and how it fits in the MARPE world?
Yeah, let's take a look. Yeah, this is just a view of that bi-cortical engagement. So you can probably see this a little bit better here. There's one cortex here, there's the other cortex here. And as we scroll through this FME that's been delivered, again, you're going to have those TADs go through that second cortical plate, but not two through it, if that makes sense. Mm-hmm. Yeah, so that's what that's showing. So this is what that looks like installed.
Wow, look at that. That's beautiful.
And again, you can see both, it's a fixed appliance. And so these are always going to be in a straight line. And you can see from front to back where that's placed kind of in the middle. And this is an 8-tad design here.
Oh, while it's on my mind, how do patients tolerate the shape and size of the appliance? I noticed that they try to smoothen it out and round out some of the, like the tad heads, for example, on the MSE always irritated my tongue.
Mm-hmm.
I've had like 4 permanent scars on my tongue that lasted for like a year after my MSE, just from the tad heads.
For sure.
What do patients say about how this thing feels?
Yeah, so I mean, really, because they have that plate that goes over top of the tads, and because the tads themselves lock into the anchor bodies, there's no tads that are protruding anywhere.
Right.
So the only protrusions are the stability arms that you see on the lateral sides. So, you know, time will tell how irritating or not irritating these are. For my patients, I haven't had complaints about comfort. Speech is still a thing for sure. Pretty much any MARPE I've delivered, most patients will struggle with speech in the beginning. Most of them will overcome that and it won't be an issue throughout the whole time. But I can never predict that either. Some patients do struggle with speech the entire time. What I will say is that oftentimes when we get to the phase of custom MARPE expansion where we remove the arms from the expander, patients say that, hey, this feels a lot better. It's a lot easier to deal with. And so, you know, not having the arms from the get-go, I do think is a plus for, you know, for the FME design. But again, we don't know what trade-offs for sure that's giving. Once we get to the point where this is predictable, then great. But do we need those arms to add stability in the beginning to get us through the initial split? Like that's the big question.
Yeah, tell me more about what role do the custom MARPE arms actually play? I could never understand, besides seating the appliance, why they're really necessary.
Well,
I know they add more anchorage to help, you know, split the suture, but
let's go back to this because I think this will help us understand that a little bit better. So specifically with, let's say you had your normal MSE, and it's very similar to this, right? All the tads are in the middle and they're all in one place.
Right.
As soon as you start expanding, this whole apparatus can swing one way or the other. Now, Basegenics is overcoming this by everything we described, or at least that's what they're trying to do.
That's the so-called dimensional stability.
That's correct.
Aspect of it.
Correct. So if you have an arm that comes off of this and connects down to these teeth here, and an arm that comes off of this and connects down to this teeth here, now, even if that screw were trying to, you know, warp or cant or tilt or whatever might happen, those teeth are an additional anchorage point further away from where the force is being applied that helps to stabilize it. And so that's why the predictability of expansion is so much higher. And in my experience, and others as well, you know, it can be very tricky if you try to do non-tooth-borne custom MARPEs, specifically if you are putting all of the tads in the middle of the palate.
Like Mariana Evans seems to like to do.
No, she attaches to the teeth as well, but she does put the tads in the middle. So, you know, that's a great question for her. I've actually wondered that as well, because the other thing you can do instead of attaching to the teeth, and I know FME has toyed around with this idea, is having some of the tads themselves angled outward. So you're engaging not only the midline bone, but you have bone on the lateral sides that are engaged as well. And that would be another way to help overcome that instead of attaching directly to the teeth.
So the FME is trying to overcome the dimensional stability advantage of the arms just by being bigger and bulkier, or how would you explain how they're managing the dimensional stability?
Well,
thing?
between V1 and V2, yes, essentially bigger and bulkier, you know, more locking. I mean, I don't know all of the details. I didn't place the version 1, so I don't know all the details of what that looked like. I mean, from the guidebooks, it looks a lot smaller and less robust. So it needed to be bigger and more robust to overcome those things. Is it big enough? Is it strong enough? Like I say, this is time will tell. And they're waiting. They want to make sure that when they release something, that it's going to be predictable. And my patients that have them, you know, we've gone over this conversation. I mean, you know, one of them already knew about it. He came in online and, you know, I talked to him about a custom MARPE because that is predictable. I mean, we've done that for a while now, and we'll go through some cases where we can get very predictable expansion. So, you know, he wanted to try an FME. Great, we can do it. You know, I understand it, but is it going to give us the same result? Is it going to give us a better result? Yeah. Those are the things that are left to be seen.
Are there any quick, like, bullet points we can hammer out about how custom MARPE might actually be better than FME in some cases?
Yeah. So definitely the rigidity of the framework, if you've seen the custom MARPEs there, it's very, very robust. And so I've never seen a custom MARPE framework fail. Okay. So that's good. Now,
What do you mean by the framework?
so the part that the TADs drill into.
Right.
Yeah. So the metal part. So that's basically what it is a 3D custom framework. And so that part where the TADs drill into is very, very rigid. Okay. So it's very, very stable. So that's a good thing. With the current limitations of MARPE, having the appliance attached to the teeth, at least in the beginning, I feel does give some advantages. Because not only is it providing that dimensional stability, but you have increased anchorage. Now, albeit it's not great anchorage, it's roots against bone, but it is anchorage. So you're connecting to those teeth have roots, the roots are in the bone. So as you're pushing, you have your TAD anchorage in the middle, and you also have your tooth anchorage. And when you're trying to overcome that initial split of the suture, I think that that's beneficial. Any increased anchorage, whether it's extra TADs or attaching to more teeth, any increased anchorage you get is going to increase the chances that you actually get a split.
Right. Let me take this moment to ask you about surgical assists with FME. Do you think FME, has it given you the confidence to opt out of piezotomes in patients that you otherwise would automatically do that for?
I don't think that that's even something that they're promoting or saying right now. The piezotome, that's reducing the resistance. That's taking care of that side of the equation.
Yeah.
And in fact, in adult males or females, when we're doing FMEs, we are doing piezotome. Again, we want to set up for the most success possible, and we want to have the least resistance possible to get this split to happen. So down the road, will they be able to design it in such a way that piezotomes are obsolete? I hope so. I mean, that would be great. I mean, Mariana's a great example of that. I mean, she's doing a lot of, MARPEs without any type of piezotome assist, and that's wonderful. But I've also seen a lot of, complications that can occur that if the resistance is less in the midline are less likely to happen. And that's why, for now, I continue to try to make that as predictable as possible by removing the resistance where I don't want it. I don't want the two halves of the top jaw connected. I mean, if there was a magic wand, if I could snap my fingers and just have a little, division between the two halves of the top jaw immediately, I mean, that's what I would do. Mm-hmm. But, you work with what you have. You relieve as much as you can, to avoid complications once you start turning.
Mm-hmm. Should we take a look at some of these appliances themselves?
Sure. Yeah. So these are the current versions of the FME 6 and the FME 8 here. And so the differences that you'll see is that on the FME 8, you'll see that there's 2 additional TADs on this anchor body itself. The middle part is very, very similar, although you'll see that these arms are longer than those arms. And again, this is something that's customized. So when they send you the case, they're going to send you the arms that fit for the amount of expansion that you are requesting. So if we were to actually, look at this.
So is the length of those barrels dependent on it being an 8 versus a 6 TAD expander? Or I'm sorry, Did we say this was a 4 and a 6?
This is a 6, so they don't have a 4. So this is a 6. This is an 8, and the 10, if you saw it, would have 2 TADs back here as well.
And this barrel just has to do with the amount of expansion that you anticipate on going for, not on the number of TADs.
That is correct. Yeah.
Okay.
So you could have a longer barrel on one or the other, or shorter on one, depending on how deep the palate was and what was fitting. So this top part here, these are the anchor bodies. So we'll just take a second and actually undo these so you guys can see it. And then you can see kind of the inner workings and underneath what it looks like. And can't do this on a patient, but it makes it a lot easier on a typodont. And so this is what's being held in place with your guide when you're actually doing the surgery to place it.
What are you calling these typodonts? What does that mean?
Yeah, it basically just means a model of the mouth, like a type or a model of the the dentition. Yeah.
Cool.
Yeah. So those come out. There's a lot of other forethought, just an example of the innovation. So when you're placing the initial anchor bodies, these same exact screws that I'm unscrewing now are actually fixated into the anchor body itself, and they're holding it in the exact position that it needs to be held. And I'll show you that once we get this out. Okay, so then this part is that part that is interchangeable, right? So this is the part that can actually just be removed. And again, if you have more expansion that's needed, then it can be, you can get a different one. So that's the actual screw portion. These are the anchor bodies here, okay? So when you are placing these anchor bodies, when you're actually putting those TADs in, there is the guide that goes over top of this, and that guide is screwed into these holes with these same exact screws. So basically the guide's there and these screws are holding it on.
So the guide is screwed onto the pallet before the pilot holes are drilled?
That's correct.
Yeah, just like in orthodontic surgery.
Yes, they'll sometimes screw the guide into the bone before they place the plate.
Right.
So same idea. So the guide is screwed on, and these can't go anywhere, right? So then you're going through the guide, and I think I have a video that shows this pretty well. You're going through the guide to place these TADs. So you won't actually see it like this when you're delivering the expander itself.
You know how some tools or some things, watches, whatever, are just really well made, and you can just tell that they're very precise when you hold them in your hand.
Right.
This seems like that sort of thing.
Well, and that's the idea, right? I mean, and we're hopeful that with this level of precision and with the engineering that's going behind this before it's launched commercially, that these things will be worked out, and we'll get to a point where we can have predictable expansion with a much more comfortable experience for the patient. And, that's the idea. But, time will tell. Like I say, I'm grateful that there's some pioneers in this space that are willing to work on this. I mean, this is in a lot of ways, a huge risk on their part. One, they're not entirely sure it's going to be able to do what they hope it will. And then two, you have to overcome all the resistance from, existing practitioners who want nothing to do with these. And so it is an uphill battle in a lot of ways, but I'll show you here. We'll actually start to remove one of these TADs, and you'll be able to see how those come out. And again, you would never do this. You would always have the guide in when you're messing with these or putting them in and out on a patient, but you can see pretty clearly.
How do you feel about the tooling that comes with the FME? Do you like it? Is it well done?
It's very precise. It's very precise, and everything's been the highest quality so far. And innovations have happened even between the version of this Typodont and the ones that I've placed in the mouth. So right now
there's the locking TAD head that's having a little hard time focusing on it, but
is it? Okay.
There's threads on that puppy at the top.
Yeah.
Let me see if I can there's a little better shot. Yep.
So as that's, go ahead. Yeah.
Little threads there.
Yep.
Okay.
So with the current version, just to simplify the installation process, there used to be two different drivers, one driver for the retaining screws and one driver for the TADs themselves. So now with the current version, it's the same driver for both, which makes it a lot easier. So you're not having to swap that out mid-procedure.
Right.
So, as you're placing it, it's going to go down again it's already been piloted. So that the orientation is as ideal as possible. It's going to thread through until you hit that anchor body. And then once you hit that anchor body, those threads are going to engage. And now it's going to continue to thread through until it's all the way down. And then this locks. You cannot overturn it. You can't go all the way through it.
No torque wrench needed.
Well, there is a torque wrench needed because if you put 100 Newton centimeters or 200 Newton centimeters of force on it, you could strip something, right? Something's got to give. But if we crank this down to where it's supposed to be, which is 35 Newton centimeters.
That torque wrench comes from Phasegenics?
That's correct. And, and implant motors have torque setting, but you'll see when you get to the appropriate torque, it's going to click like that.
Wow.
So that that one, it's all the way secured down. It's not over torqued. It's not under torqued. You're good to go that way. So then you're going to put the screw in, and this is done. This is the part that you don't need a guide for, essentially, because everything's already in. The guides are used to place that. Once that's placed, you're going to place this in. You're going to want to make sure you don't place it backwards. If you place it backwards, you're going to have to turn from bottom to top instead of top to bottom. So you'll place it in. And once it's in, then you'll place the retaining screws.
This is the fun part.
Right? You want to put them in?
No. No. I could handle it. I did used to be a mechanic, so.
I wouldn't know how to run the camera though, so it might be a disappointment. So those lock in, and then you'll screw those all the way down. These torque to 40 Newton centimeters because it's metal on metal, so it's going to be a little tighter. So once you get them close, you can crank it up to 40 Newton centimeters, one setting higher, and then you can do the same thing. You're going to lock that in. I haven't got it yet.
Do you think? Yeah, beautiful. I used to always love that click on a torque wrench.
Yeah, it's satisfying.
When I was a mechanic, one thing I noticed was that not many other mechanics were actually using their torque wrench. They were just sort of slamming stuff on.
Yeah.
Do you think it's kind of like that in dentistry too, where you just get some people putting in MARPEs without really being that careful about proper torque and all that. What's your experience been with that?
Well, what I will tell you is that there's a lot of complications that I've seen from other practitioners that I haven't experienced myself. And, I don't know the reasons for those complications because I wasn't there. But, when I hear about the head of a TAD stripping or, breaking right in the middle or things like that, it does make me wonder, like, how much force is being applied? Are the TADs binding? Like, what's requiring so much force that the actual metal of part of the appliance is failing? And so, my guess is the more precise you are, the less, and the less kind of, I don't know what the right word is, but, the more care you take in making sure that the forces are not excessive, the less likely you are to have some sort of complication failure, specifically as it relates to the equipment that you're using.
Before I step away from these typodonts, I want to try to get a visual of that space that exists between the appliance and the palate. Yeah, there it is. So that large gap is intentional, and that's part of the orienting the appliance?
Yeah, so you would have to ask FME exactly how they determine how much that gap should be. From my standpoint, if we're starting from ideal and working backwards, the framework would be as close to the bone as possible, because again, the closer that metal framework is, the less stress and the less torque, right? The less torque, lever type torque that you have going from the appliance to the bone. So in my opinion, it's not better from a mechanical standpoint for it to be off the palate. So my guess is that it's as close to the palate as it can be to make the system still function.
Yeah, Dr. Nuaz specifically brought that up as an area that could potentially be improved in future iterations of the FME, was that gap.
For certain. And if the anchor bodies were customized, let's say, so instead of having a prefabricated anchor body, if those anchor bodies were customized, we could put TADs laterally, extend them further back, front, very similar to how custom MARPEs are designed, but yet still maintain the advantages of the guided surgery, then, in my opinion, that would be more predictable. But is that necessary? I don't know. If these work the way that they are, great. And if we can get predictable expansion on everyone with them, great. It's much more simple this way. But if not, then we continue to innovate.
All right. Anything else we need to see on these typodonts, or that's pretty much covers it? Yeah.
That's good. Yeah. This is a patient that had already had an osteotomy type procedure done, and this was his progress a couple weeks later. So we're starting to see the diastema there, which is great news. So again, and we're not seeing a ton of distortion of the appliance or anything else like that yet. So I'm hopeful that this will be what he needs. This is another one. This is on a younger teenager. She's about 16. And you can see here at the delivery, this was the activation here. This is actually a good point. So I will pre-activate the appliance when I deliver it, or rather, as soon as it's delivered, I'll activate it for them to teach them an appropriate amount of pressure to push and what's too much pressure. Yeah. So you can see here that small gap is where the appliance has been activated chair side after it was delivered. This is a couple weeks later. She didn't take the best photo. This is an example, though, of the grin that you'll see. This is a scan that she sent in. You can see that gap there is getting larger. And then, of course, you can see the gap between her teeth on that same scan from the front. And then just a few days later, we're starting to see that diastema widen. And this is that smiling photo. So you can see so far, we're maintaining really good symmetry. The centrals are, parallel one to another. And so far, so good.
Yeah. When FME first started being mentioned about, I don't know, a year ago, 18 months ago, I thought it was some sort of publicity stunt, to be honest with you, because it was almost like I was being spammed with questions about FME, and it was being treated like a messiah of some sort, right? And I've been giving it a lot of attention recently, with my interview with Dr. Nuaz, a Substack article I posted, this interview with you. Is it possible that we're jumping the gun on this, and that it's really not going to be everything we're hoping it's going to be? Or do you feel pretty confident, or do you think agnosticism is probably best and most prudent for another year or so?
That one for sure. And that's anything, right? I mean, so until it's tested and we really have good solid data, and again, we'll go through some cases, we can see now there's no excuse to wonder what we did with the case. We can see 100% crystal clear 3D superimposition. What moved? Did the bones move? Did the teeth move? We'll go through it together. And with that knowledge, we can take these cases, these pioneers, people who want to, try this before everybody else, and we can see how successful it is. In my opinion, it needs to be proven. And what's interesting about this is that it's not FME going around and spreading the word. It's not Facegenics. You know what I mean? It's not them that are spreading the word about this. They're continuing to refine, to get feedback from docs. They're continuing to do the research side of it, which I think is very wise.
Yeah.
But it's everybody else who's talking about it, saying it's the next greatest thing. I am not going to say that until I'm confident that it is. I'm optimistic. For the reasons we explained, I'm hopeful that it will be better for the patients, better for us, more predictable. But no, I haven't seen that enough to say, hey, I'm going to recommend this over something I know is going to work.
And even if it is significantly better than other technologies we've seen in this space, it's also not the end all be all. This isn't where MARPE innovation ends, right? We've already been talking about some things where there's room to improve about the FME, but this is potentially just a step forward.
Correct.
Yeah, kind of like how custom MARPE was a step forward from MSE, and now maybe FME is a small step forward from that, but there's hopefully going to be more steps forward after this from Facegenics or otherwise.
Correct. And going back to their innovation, so they're actually looking at pioneering an entirely different way of doing protraction therapy. Having basically a completely separate type of face mask that we've never seen before. I'm not privy to all the details of that, but again, that's something that excites me. It's face mask therapy has been around for probably over 100 years. I mean, it's been a long time that we've been protracting the upper jaw forward, primarily in kids. So, they're looking at being able to provide a force system that can do that, definitely in kids and maybe in adults, in a way that we're not taxing, the chin and the forehead, which is what's typically used for protraction face masks. We don't want the chin to go back. We don't want the force to be put on the jaw. So they're looking at, pioneering new ways to do that as well. And then as Nuaz mentioned last podcast that you did, if you have the ability to apply force from outside the mouth to a system that's inside the mouth, not only can you make that force straightforward to try and bring the jaw straight forward, but if you start to develop any asymmetries due to differential resistance, whatever may cause it, maybe even a fracture, well, now you have a separate force that's not part of that system that can help guide and direct where that expansion is going. And that's exciting.
Right. So you're kind of painting the picture of a protraction system that's not just necessarily something to help interiorize the midface and the palate, but something that can just be used more generally to help balance asymmetries that exist in the expander.
Absolutely. Not necessarily in the expander, because if it's planned out right, it shouldn't be there, but in the expansion process.
In the complex.
Yeah, exactly. As those turns are happening, for whatever reason, it's not going the direction we thought it would.
What are your thoughts on protraction in general? Have you seen the FME proprietary expansion system?
Not in its entirety. And again, I don't believe it's out yet in its entirety. So, I've seen little pieces of it and parts of it, and it's just like you would expect. I mean, down to the most minute detail. It looks different than anything I've ever seen.
No kidding.
Up to this point, majority of practitioners doing protraction are going to do the traditional chin, forehead, face mask.
Yeah.
You might have some doing the bow, which I've done some of those. You might have some doing the crane. Those come with a significant set of challenges as well for anybody who's done either of those.
Yeah, it's funny. In your online course, you mentioned the lack of a really solid, stable option for actual face mask devices as being one of the problems in the protraction space right now.
Right.
And you said, hey, if anyone is looking for an entrepreneurial venture, go out and solve this problem, make a better face mask.
For sure.
Right? And maybe Facegenics is doing that. Are you bullish on face mask, the future of face mask in general, or do you use it a lot in adult patients? What do you think about it?
So in growing patients, 100%. I mean,
what's a growing patient? When does that end? That's also a controversial question.
Yeah. So let's just say up to 16, 17 in females and maybe 18, 19 in boys.
Oh, wow.
Like for sure. You're going to, because that growth is happening, it's not so much just bending a bone like it would be an adult where there's no growth. In an adult bone, you have two things. One, the bone is harder. Two, it's not growing. In a growing patient, those sutures, all those areas of resistance are active. So they're not just stable, locked together, and that's where they're going to be for the rest of your life kind of thing like an adult. They're active. So when you apply force, it responds in a different way than if you apply force to something that is, rigid and stable like it becomes in adults.
Right.
And so any growing patient, you apply enough force for a longer amount of time, you're going to get movement of the jaw to a higher degree than you would in an adult. So the question is, can you take a fully formed adult skeleton that's no longer growing, all the physiology of growth is shut down at that point. You just have sutures, you have the interlocking of the bone and any type of fusion that's there. So essentially you're asking the top jaw not to grow forward with guided force to help it grow forward, you're asking it to bend forward. And so how much can that upper jaw bend forward? That's left to be determined. So far, I have not seen it. And I've had patients who want to try face masks, and I let them try it. I mean, there's nothing, in my opinion, that's super dangerous or risky about it. It's just that it may not work. As long as it's attached to your anchorage and your anchorage is solid in the bone, then you're not going to have problems in doing it. But how much do you wear it? How much force do you apply? And how much actual movement does that cause above and beyond just the mechanical movement of the jaw due to the expander?
Right. Yeah. People have differing views on that. I tend to be more in your camp where I'm not really that excited about face mask as an option for adults. If for nothing else than just the compliance problem with face mask. It's a miserable thing to wear.
Right.
Okay. Well, we've talked for the whole first hour about FME. I want to pivot a little bit to another big question in this space, which is MARPE versus segmental multi-piece maxillary jaw surgery.
Okay.
What are your thoughts on what MARPE can do better than segmental jaw surgery, and when do you think that segmental jaw surgery is a fine alternative for some patients, maybe specifically those that don't present with distinct nasal breathing problems?
Sure. Yeah, so we'll back up, and I want to start with, not specifically segmental, because segmental, it's like how many segments? Is it 2 segments? You split down the middle. Is it 3 segments? Is it 4? So there's a lot of complexity as far as what you can do depending on how many segments you put the maxilla in. But let's back up to SARPE, right? I mean, because SARPE's been around forever. And you put an expander on the teeth, you're not connected to the bone, the surgeon cuts, and then you expand, and the teeth are the anchors. So I think that SARPE will eventually become extinct, and to a large extent, I think not many people who are doing MARPEs well are doing SARPEs at all anymore. Because with the SARPE, you have just a split down the middle. And so you're expanding just the top jaw, and you're expanding it in 2 halves. That's what you're getting. And the downside of doing it with the SARPE method is where these cuts are. So when you're cutting at the floor of the nasal cavity here, then the only part that's expanding is below. And so now you have a surgical procedure, which is much more aggressive than something like, a corticotomy or an osteotomy in the midline. And as you expand, you're not getting the expansion higher up. Now, if you feel like your cheekbones are already prominent and you don't have any nasal breathing issues and you don't want any changes to the upper part of the face, well, that may be a great way to do it.
Right.
Because I can't expand your jaw skeletally orthopedically without some changes to the face. Now, they may be minor, not noticeable, but there are patients who aesthetically are not great candidates for MARPE because as the expansion happens, they may have a small upper jaw, but as the expansion happens, it may create negative effects on their face or their smile.
Like they may have a small upper jaw, but they might still have prominent cheekbones.
That's correct. That could be the case. Or what's more common is, we haven't talked a lot about this yet, but the amount of vertical that they have. So if they have a really gummy smile already, they smile, they show all their teeth, they show their gums. As this expansion happens, and I'll take a second to show this because it really is a little bit, he doesn't need his lower jaw anyway.
Nah.
So as the resistance is up here, you can see any place where these bones connect is resistance. So here's where the maxilla connects with the zygoma. So that's resistance. Here's where it connects with the nasal bone, with the frontal bone. So this is where your resistance is. And when you just look at it, the resistance is posterior. So you see where the jaw and the teeth are, it's more forward. The resistance is posterior, all the way back here to the pterygoid plates and the palatine bone. All the places that have resistance are more posterior, and they're also more superior. So you can see that the jaw is like the lowest thing down.
Right.
So all of the resistance is higher up. And so that's why when you expand, you'll see that as it opens up, the midline suture will split, but yet you can see how that whole, do you see how it comes down?
Yeah, it sort of falls forward.
Yeah, do you see how it falls forward?
Yeah.
So if you've really gotten a split of the maxilla, you are going to see this downward movement of the maxillary complex, which if you already have, do you want to take a video of that?
Yeah, let me take a video of that.
Yeah. So pay attention to the area between the nasal bone and the frontal bone there. As this just expands, everything else is bending, but you see mechanically that is putting tension in that area and it's bringing the upper jaw down. So as those sutures bend, you'll see this remodeling. In fact, I think I have a case later that you can actually see it on the x-ray, this area moving like this. And so you'll see in addition to coming down, it's also going to come forward. So if you look from this view, because of where the resistance is, it's going to be moving forward the more you expand.
Yeah.
And this is where I think a lot of patients and practitioners get mixed up. They expand, they say, maybe they're using a face mask and they're saying, look how far forward the jaw is coming. But really, it's just a function of the expansion and where the resistance is. The jaw comes more forward the more you expand. And so if you have an 8, 10, 12 millimeter skeletal expansion, yes, the jaw is going to come more forward than if you have, a 1 millimeter skeletal expansion.
Right. Or as we were talking about yesterday, the famous scolopendra case that had a 20 plus millimeter maxillary expansion, I think 2 custom MARPEs, might have been 2 MSEs, I'm not sure. I think he's a young man, so it might have been MSEs. His maxillary advancement was significant.
Yeah.
And I have some photos of that on my Substack, where it almost looks like he had a maxillary advancement via jaw surgery.
Yeah.
And some people say, hey, that was because he used the face mask with the big MARPE expansion. But you're maybe playing devil's advocate here. You're saying, hey, wait, this could just have been the interiorization of the palate that naturally resulted from the expansion. As we just showed, expansion always results in the palate, or generally results in the palate coming forward and slightly down.
Well, really always if the bones are moving.
Right.
If all the bones are moving and the resistance in the middle is completely obliterated, then that's the direction it's going to go. But if the anatomy is different, and we'll go through some cases where you don't see a lot of anterior movement, there's partial resistance somewhere, whether it's in the nasal cavity, something's happening to where it's not releasing the maxilla enough to come forward.
And this is to your earlier point where you were bearish on protraction in adults. Some people might say, hey, look at the scolopendra case, or hey, look at some of the cases that, Dr. Lipkin has put out where a small class 3 is corrected with MARPE and face mask. And Isa Chimile also has some on her Instagram page, small class 3s corrected by MSE and face mask. You're suggesting that could have just been the MARPE.
Well, this is a perfect segue into this case. Let's look at this case. This is a 40-year-old adult male. Okay, so when this patient came to me, I told him, hey, look, you're going to need jaw surgery. I was like, we can do a MARPE first because you're very deficient in, the nasal breathing and everything else. You can see his smile display was not excessive. If anything, you can see he was not showing all of his teeth. So this is the before and after. He had a MARPE for 9 months.
And you thought he needed jaw surgery as a class 3? Because he was sort of tip to tip there?
Yeah, exactly. Edge to edge here. And then also, with his symptoms that he was having, would he need an MMA to bring everything forward?
Yeah.
But even just with the amount of discrepancy, from a width standpoint, it's not always predictable to get that much skeletal expansion. So I'm always going to err on the conservative side. Before I jump into a case like this, I'm going to tell you, hey, you might need jaw surgery. And I would plan on having jaw surgery. And so that was the conversation that we had in the beginning. So the MARPE was to help and assist and to make the surgery, movements be less, because we've already accomplished some of the expansion with the MARPE itself. But as it turns out, we didn't end up going to jaw surgery with this patient. And I want to show you what that looks like. So he had the MARPE on for 9 months, braces for 15 months, and then clear aligners at the end for 2 months. So as we go forward, this is the before and after skull views here. All right, so you can see on the left here, you can see where the bone initially was and where the teeth initially were and how they fit together. And then this is the after view after those bones have broadened and moved. And
looks beautiful.
We'll show you exactly how it looks, because again, we can look at it in even more detail. So this is another view of it. So you can see here how the teeth were fitting, bilateral crossbite and edge to edge in the front, more of a class 3 tendency. And then if we look here, this is how things are set up from the very, very beginning. So this is where his teeth actually were. So you can see here the amount of cross bites that's happening here from the first molar to the first premolar here. And he also has a significant amount of crowding on the bottom that needs to be worked out. So this is what the top jaw actually looks like. He had these lateral incisors, which were pretty small as well. And that's a common thing that a lot of patients have. You know, the smaller those teeth are, the harder it is to get the teeth to fit together. So in his case, we ended up recommending that those be bonded. So this is kind of the pre-planning with the braces, what that looks like. So the teeth are basically set up to go to the ideal location within the software. And so once we have the teeth in the ideal location, then the software does the reverse engineering. So we go from ideal to where the teeth are now, and it places the brackets where the teeth are now to get this result. You can see here on those lateral incisors, we're aligning the gum levels. You can see on the front teeth, we're aligning the gum levels because you're going to have these teeth that are worn down, restored. And even back to the wisdom teeth there, we're planning out every detail of this case so that once the braces in his case go on, that we will be able to go hopefully in as straight of line as possible from brackets on to braces off. The same principles apply if you're working with clear aligners. So the same type of workups happen. You have where you're starting and you have where you're finishing, and then everything is designed to get you there. So that was kind of what his workup looked like and the plan was. Once the expansion and braces were done, this is where his teeth were at that point. So you can see here, there are some dark triangles here. We're doing some reduction here. And it was only about 5 trays to close down those teeth and get him ready for the dentist to final restore those teeth in the front. So you can see here a very simple process. The braces have done most of the heavy lifting in this case. And then with just these 5 aligners here and these little red numbers indicate interproximal reduction or smoothing between the teeth so that we could bring those back slightly and make those dark triangles smaller. You can see that from this view as well. The teeth are coming back a little bit. As they come back and get closer together, the dark triangles between the teeth will reduce. And so now the question begs, well, what happened to the jaws? And 3D superimposition is how we find out what happened to the jaws. So this here, if I were to just show you this, and let's just say, for instance, that, I told you this patient used a face mask. I think most people would be pretty impressed with the changes that they see. You can see the forward movement of both the top and the bottom jaws. And again, this is a 40-year-old patient.
Can you loop that one more
we'll
time?
Loop that again. Yep. All right, let's put it on a loop here. There we go. So you could, and I didn't measure this out, but I mean, it's to the tune of, 4 or 5 millimeters, somewhere in that frame. And this is something that's interesting that I don't think we talked about yesterday either. When the upper jaw comes forward, oftentimes the lower jaw will come forward with it. Now, the jaw's not changing, meaning the bony structure of the jaw.
Of the lower jaw.
That's correct.
Yeah.
That's correct.
Which is a very important point that you just made, because I think a lot of people who get into the mewing world, and they're told that if they can expand their upper jaw, that the lower jaw will just somehow magically mimic it.
Yeah.
That it will just grow to match it is not the case. But what do you mean when you say the lower jaw will come to match it?
So the lower jaw sits within a soft tissue framework in the articular eminence here that's coming off the base of the skull.
Let me come closer on this.
Yeah. So this space, can you see it?
Yep.
This space here is fluid to some degree, meaning that the jaw could fit here, the jaw could fit here, the jaw could fit here, the jaw could fit here.
That's the temporomandibular joint.
That's the temporomandibular joint. That's correct. And there's a disc that sits on top of it, and there's ligaments that kind of hold everything together. But depending on where this jaw goes is often determined by where the teeth fit together. So if the teeth fit together here, then that jaw is going to be more forward and function there. If the teeth fit together here, which is often the case with your underbite patients, what's been happening is as they've been growing, they've had forces on their lower jaw to push it back within the fossa because, as they try to grow, the lower teeth hit the top teeth. And as the lower jaw grows forward, the top teeth are stopping it, and it results in this pressure on the lower jaw that pushes this condyle back within the fossa. So when you expand the upper jaw and the upper jaw comes forward, it allows this area to relax, and it can go in the center of the fossa. And so oftentimes we will see that, even in adults, we'll see that lower jaw, it's not growing forward, it's just relaxing forward within the fossa.
It's reposturing.
It's reposturing forward, yes. And as long as that it repostures to a position that's repeatable and stable, typically the place that causes the least force on the jaw is the most comfortable and the least likely to have jaw problems down the road.
Right. Yeah. Thank you for that visual on the TMJ, by the way. So let's get back to this. So you're saying that when the the maxilla comes forward with a MARPE like that, that can be healthy for the temporomandibular joint. It can decompress the joint and allow the lower jaw to posture forward a bit, which also confers some aesthetic benefit too. It helps pull the gonion out from inside of the neck and sometimes gives you a little bit more of a jawline.
That's correct. And everything attached to the lower jaw comes forward as well. Now, is it significant as far as, is that going to help you breathe better, sleep better, not obstruct as much? We don't have enough studies to say, yes, if that comes forward 1 millimeter, then your AHI is going to reduce, or whatever metric you're using is going to reduce by X amount. It academically makes a little bit of sense that if you're having obstruction and there's blockage, if there's, a bigger diameter or more room back there, that maybe that would happen less often. But again, I can't go out and say that because we don't have the data to back that up yet. But this is where things are going. I mean, as we do these cases, we're learning.
Yeah. Well, mandibular advancement devices do just this, right? They help the lower jaw slide forward a little bit, but with a lot more negative side effects in the medium and long term probably than actually moving the palate forward to allow the lower jaw to permanently position forward.
That's correct. And just to be clear, when you're talking about a mandibular repositioning appliance, I mean, typically you're moving 2, 4, sometimes 6 millimeters. It's a big jump. So something like this, although it's significant, I mean, we're looking at, if you look down at the chin here, right? So some of this is rotation of the lower jaw forward. Let's see if I can zoom in so we can see this better about that. But if you focus down here on the chin, the actual chin movement is much smaller than the rotation of the lower jaw forward. So if you're looking here, you might think that the lower jaw came forward more than it actually did. Actually, I'll show you the view that tells us exactly how far forward the jaw moved. And so this is like you're looking up at the skull here, and I'll loop this so we can see it. So this is as if you're looking from the bottom up, like straight at the bottom of the skull. So at the top of the screen here is the nose. This is the internal nasal passageways, and these are the sinuses here. So, and these right here are the condyles, okay? So this is the actual jaw joint that we were looking at from the side a moment ago. So you can see between these two images, in his case, the right side came forward quite a bit more than the left side did as that expansion happened. Now, again, we're not doing anything on purpose to move those jaw joints. Those jaw joints are going wherever they go. They're going to relax to whatever position that is most comfortable for them. We're just taking the teeth out of the equation for a minute, because as that expansion process happens, the teeth are discluded. So they're not functioning and fitting together the way that they always have. So now the jaw's like, oh, well, where do I go? And so in this case, the right side of his jaw wanted to go more forward and the left side came forward a little bit. But you can see here too, look at how close these bones are in the initial and how much further apart they are in the final. So a lot of times when these bones get too close, well, you take it to the extreme, they can actually wear through the disc or wear through those ligaments, and you can start having bone-on-bone contact, which is typically painful and progressive. And so then you have, TMJD or whatever. Right. But ideally, you want as much cushion around that joint as possible, and you want the jaw to be relaxed in the best position it can be.
Do you think that it's also problematic to have the lower jaw postured too far forward? Is it maybe not as bad as being too far back?
Yeah.
But
so it depends on it. So there's some nuance when you say the word posture. So when I think of posture, I think intentionally moving the jaw somewhere that when it's relaxed, it won't go. So I can posture my jaw like that, okay? But if I fall asleep, my jaw's not going to stay there.
Correct,
okay?
Or when you smile.
That's correct.
Yeah.
Now, when we look at something like this is not a posturing forward of the jaw itself. What it is a relaxing and a remodeling of the soft tissue of that jaw joint.
Understood.
So that when your jaw is relaxed, it's just in a slightly different position than it was in the beginning.
Understood. And where I'm coming from is that I personally do this, and I see a lot of other patients that do this, where I guess it is just a kind of relaxation. It's not an active jutting, but I think a lot of patients don't, they're skeletal class 3s, not dental class 3s, because when they bite together with their molars touching, it looks normal. But when they relax, their lower jaw falls in front of their upper jaw. Mm-hmm. And why patients do this, why do I do this? Is it a neuromuscular thing where it causes relaxation at the neck because of muscle tension? Or is it an airway thing where you're just trying to bump your mandible out of your throat so you can breathe better? But I often worry that this is not a good habit to have, because you don't want the joint to remodel around a position that's not in accordance with your actual bite.
Right. Or if you do have it remodeled in a position that's not in accordance with your bite, you want to fix your bite to match there.
Which is not easy to do if it's an AP problem.
Exactly. Yeah. And then there's the rub, right? So at what point, where is your lower jaw? Where is the condyle the most comfortable? Whenever I treat a TMD patients specifically, right, the first thing that we do is we essentially deprogram them. And we do it in a little bit different way than other people do it. But we use what's called an in-mouth bite splint. And what that is basically just buildups on the teeth that get them off their teeth. And
it just discludes them?
Just discludes them. Yeah, just a little bit. Because the more you disclude them, the more uncomfortable it can be and the harder the time they have tolerating it. So you disclude them just a little bit. You have supports in the front, you have supports in the back. So compliance is 100% because it's glued to their teeth while it's on there. And what that does is it takes the teeth out of the equation. Now the jaw can go wherever it wants to go because there's nothing stopping it from going to the left, to the right, forward, backward, wherever it wants to go, it goes. As it goes, you'll notice that those bumps become uneven because, well, now it wants to go this way. It's hitting heavier on these bumps. So, well, now we adjust those bumps. And now where does it go? Until you get to the point where it doesn't go anywhere. It just stays where it is. Well, now we take a look at the bite and we say, hey, this is where your jaw wants to be. And at that point, typically the symptoms are gone. If it's kind of your run-of-the-mill, TMD type symptoms. So at that point, it's like, well, what do we need to do to get your upper jaw and your upper teeth to match that? Maybe it's just braces. Maybe it's aligners. Maybe it's a little active retainer to move one tooth. Maybe it's an equilibration of the teeth. Hey, we just need to, adjust this cusp here, that cusp here. It's going to be different depending on where that jaw goes. So once you know where the lower jaw is relaxed and comfortable and where the jaw joint is the most comfortable, then you can work backwards from there and say, okay, what do we need to do to get the upper jaw to accommodate and the upper teeth to accommodate and the bite to fit together there?
Yeah. And probably sometimes there's not an easy orthodontic solution to that. Sometimes you just need maxillary advancement.
That's correct. Sometimes the discrepancy is so large that we cannot overcome it with any type of traditional or even progressive MARPE type of treatments, and we need to have jaw surgery to do that.
Yeah. 2 more questions about the mandible before we let this go. Well, 1 question about the mandible. One thing I've always had a hard time wrapping my head around was this idea that intrusion often occurs is pursued with MARPE treatment in order to try to help the lower jaw hinge or swing forward. Mm-hmm. Can you demonstrate what that means and why that's important? I know you mentioned that in your course as well, which is why I know that it's
going to be really hard to demonstrate just because I can't move the upper teeth and jaw up. But we can do it. We can do it in a different way.
Yeah.
So we just have to. We'll take some creative liberty here. Let's just assume that that the lower teeth are taller than they are, and they're actually touching right now, right? So it's like I know that the jaw is open, but let's pretend it's not. Let's pretend those teeth are longer and they're actually touching the upper jaw and the upper teeth exactly where they are right now. If you were to intrude those upper teeth, it would create space between the upper and lower teeth, just like you're seeing here. And that would allow the jaw to come forward because it goes on a hinge. Now, how significant is that? So look at this. So let's say that this is 2 millimeters of intrusion, which is actually quite a lot. It doesn't sound like a lot, but 2 millimeters of intrusion at the back teeth, it's about that much.
Is it normally just the back teeth that are intruded, or does it all depend? Is it patient to patient?
So the back teeth are the hardest to intrude because they have the biggest roots. And the more you intrude the back teeth, the front, basically the back teeth are the limiting factor is the easiest way to explain it.
Okay.
It's going to be a lot easier to get the front teeth intruded than it is going to be to get the back teeth intruded. So let's say you do you do some amazing intrusion and you get 2 millimeters of intrusion of the back teeth, which will be more of the front. You can see up in the front, it's probably closer to 4. But let's just say that that's, that would be a lot. We'll put it that way. This is how much movement you're going to get of the jaw, that much. So is that significant? I don't know. Is it a millimeter? Is it a millimeter and a half? Maybe best case. Is that significant? That's what we still don't know. Right. But in my mind, that's a lot of intrusion. That amount of intrusion will absolutely affect your smile and how things fit together that way. So a patient that has a gummy smile, yes, we'll do this. And if it helps the lower jaw come forward a little bit and that's helpful, great. But personally, I would not set out and say, hey, look, this is our plan. You want your lower jaw to be forward. So we're going to go ahead and intrude the upper teeth and get it forward that way. I would be much more inclined, if they had a transverse discrepancy, just do the MARPE, get the mechanical movement of the jaw forward and let the rotation happen that way.
Right. Yeah. Thanks for sharing that. And also, while we're on the subject of the forward movement of the maxilla with MARPE, Can you demonstrate the misconception that often occurs when people get confused about, does the maxilla come forward with MARPE, or do you actually get a caving in of the front teeth with MARPE because of the gap that's formed or because of the stretching of the palate? And we know that the answer is that both are kind of true.
Right.
And can you explain that distinction?
Absolutely. So when we
I believe you had a tool that you...
Yeah, we'll bust out our handy lab tube. Okay. So, when we look at the teeth, you have to think of them as being separate from the jaw. So the teeth, although they are connected to the jaw via the periodontal ligaments, in a way they're separate because they can move independently of the jaws. When we do adult braces or aligners, the teeth are moving independent of the jaws, all right? Just your normal standard run-of-the-mill treatment. So you have to think about them as independent even when we're talking about expansion. So if the teeth are independent, they are connected to each other by elastic ligaments. So this tooth connected to this one, connected to this one, it's very much like a bungee cord. So if some of the teeth are moving one direction, then that's going to affect the way that the other teeth move, even if there's not an actual force on the teeth themselves. For instance, when you see an upper palate develop super narrow and you see the outsides of the teeth come in and it creates that mid-arch, collapse basically. Same idea. As those teeth are pushing, the cheek's pushing, it's pushing those teeth in. The teeth are following. You never see just one tooth going in. They go in as a group. Right. So they're
one big interconnected piece of tissue.
That's correct. Yes, they're connected by elastic ligaments. So as you expand, the bones are moving. All right. Now we know that the middle of the bone is separating, but those elastic ligaments haven't been separated, unless you've gone in and cut them, which most people don't do because that's risky and has complications. So the elastic ligaments is everywhere are connected still. So as you expand, you're going to see that initially you're going to see the upper teeth come back. It doesn't mean that the jaw's coming back. It doesn't, likely the jaw's going forward if you've actually gotten the bones moving. But because the posterior segments of the teeth are moving so quickly, the anterior segments are what gives. And so you see this initial retroclination or tipping back of the anterior teeth. And then once the jaw is stable, well, now you can use whatever mechanics orthodontically, whether it's aligners or braces or whatever you're using, to restore the teeth and to move those forward and essentially to move this entire unit forward.
Right. So is the workflow to allow the teeth to collapse temporarily and then you move it forward later with Invisalign or rather with clear aligners or braces, or do you stabilize the front teeth during expansion to kind of prevent the collapse from ever occurring, as like Dr. Yousefi and I believe tries to do that? Because I've had patients complain to me that, oh my God, I'm expanding and my upper lip is getting weaker. What's going on? I thought my palate was supposed to come forward, and they get scared.
Yep. So to answer your question, it's a lot easier to control for that with braces than it is for clear aligners. So braces can be on the teeth during that whole active part of expansion. So if you are pushing the teeth forward actively with the braces, maybe like springs on the side, and you're basically overcoming that natural elastic force by the braces, then absolutely you can keep those teeth forward. You can even push them more forward than they were. You have control that way. But if you're trying to do clear aligners, it's very difficult to do clear aligners when you're actively turning an expander, because every aligner would have to be exactly matched up with the amount of turns that you get. And then it's not always a one-to-one when you turn how much the jaw moves. So you're playing this game of like trying to control that in ways that are not super predictable.
People do that though, right? I could never understand it.
Yeah, it can be done. Yeah. So, if you want, let's just say that you were really, really paranoid about getting a gap, then you could, with enough time, efforts, and patience, you could design aligners that go on the teeth that are not attached to the MARPE, assuming that you're doing a custom MARPE and they're attached to some teeth. So you put the aligners on the teeth that are not attached, and you can apply those same forces to push things forward as the expansion is happening. But every single stage has to be coordinated with the turns that you're doing. Otherwise, you just turn too much and the expansion overcomes and that the aligners don't fit anymore. Or, you don't turn enough and it's trying to basically push the teeth out of the bone because the bone's not there yet.
Or the clear aligner just resists the expansion and becomes another force preventing the turning?
It is a force, but when we talk about the transverse force of a clear aligner, it's pretty weak. Yeah. So that wouldn't be something that I'm overly worried about. But it is strong enough that if, let's just say you have your aligners programmed to make the jaw this wide, let's just say you weren't turning correctly or you weren't turning at all, it is enough force to start to push those teeth to the limits of the bone. And so, if it's not being monitored, or, you just go off and you're wearing your aligners, but you're not, turning your expander on schedule, however it was designed to be, then you could potentially have a situation where you're either tipping the teeth out or potentially moving them out of the bone.
Got it. Is there anything more we should see about this gentleman's case? Did we want to
No, I think
put a ribbon on that, or is that all
I think
set?
that wraps up, but we can compare it to a couple other cases if you want to stay on the subject of anterior movement, where we see cases where we didn't have anterior movement.
Please.
Yeah.
Because I don't want everyone to think, oh, I'm going to be guaranteed to get a 2 millimeter maxillary advancement with my MARPE.
That's
because
correct.
it definitely doesn't always occur.
Yeah, that's correct. So this is a before in progress. So a couple of the things that we already talked about. You can see in the initial images, blow this up a little bit bigger. You can see in these initial images, there is an existing maxillary skeletal cant. So you can see that it's higher up on the right than on the left. So, ideally, if we could, make this a little bit more even, that would be a lot easier way to try and align this and hopefully correct some of this as we go. This was set up kind of our more traditional way in the midline of the palate and also according to the occlusal plane. So as that expansion happens, as we would expect, we're seeing the left side come down more compared to the right side. So you can see that there's it's accelerated or exaggeration of the cant that was already there, okay? So this is as the turns are happening. You can see, we've gotten a few millimeters on each side, so 6 or so millimeters at the screw there. And then if we go to this image here, you can see, and this is just something I wanted to bring up briefly, back to the conversation about when your bite affects your jaws, your bite also affects your teeth. So these are the initial images here. Because she's been in an underbite for so long, you can see the force that has been pushed, basically put on these lower teeth, and you can actually start to see the teeth pushing outward toward, basically out of, close to out of the bone at least. They're pushing more forward than they otherwise would due to the bite. So let's go to this now. If I were to show you this case, and if this were the only thing I were to show you, you would think like, wow, that's a really great result. Like you got expansion, like both halves of the jaws moved, like that was really, really good. And I'm not saying that this wasn't a good result, but what I'm saying is that it may be deceiving, if you're only looking at one aspect of it. So when we look at the parallel expansion, so to speak, again, you can see where her TADs were. She had 6. So she had 2 more in the anterior and then 2 more in the posterior, to my point about trying to engage both sides. Initially, the MARPE was attached to the teeth as well, at least until the initial split was formed and that resistance was overcome. And when you look from the back to the front, I mean, I would argue it's pretty parallel, right? There's not, yes, it's always going to be a little bit more in the front than the back, just due to the resistance like we talked about. But when I see expansion like this, I'm pretty happy. I'm like, that's pretty parallel, okay? So, but now let's look at what happened from a front to back standpoint, okay? So this is the same case here. You can see here the jaws moving, but you can also see the teeth moving. Now, when you looked at those photos initially, it wouldn't be so obvious that the teeth have moved so far and that the jaw hasn't. If I were to go back and I were to say, hey, like, what's going on with this case here? Yeah, the top teeth look like they're tipped forward a little bit more. For sure, you can see they're more tipped back here, more tipped forward here. But I would not have guessed how far those moved until you actually lay the before and progress images on top of each other.
Right, you might have thought at a glance that it was a mostly skeletal correction of the class.
That's correct. I would have guessed like, hey, that's great. We're getting a lot of forward movement of the jaw at the same time. Whereas really this is primarily from the AP standpoint up to this point, this is a dental and a dental alveolar correction, meaning that the teeth themselves have moved and the bone around the teeth has bent in this area here. So, is that okay? Yeah, it's okay. We can do it that way. That's how we've always used to have to do it.
And by the way, this patient, I believe you recommended jaw surgery for this patient.
That's correct.
Right?
That's correct.
She didn't want to have anything to do with that.
That's correct. And unfortunately, I mean, that's a lot of patients, because not everybody has access to a surgeon that can do it. There's additional risk and there's additional cost.
And pain.
Exactly. Yeah. Well, yes, and at least, pain, absolutely. The recovery period is most people are going to say 6 weeks, but certainly for the first week or 2, you're probably not heading back to work yet. Whereas, something like a MARPE, you're probably going back to work the next day.
Yeah, I think this is such a case in point as to why you should never judge photographs on the internet as to what's happening in someone's face, because you just don't really know what's happening until you look at the radiograph. Here, it's really not a skeletal advancement. It's a dental or a dental alveolar advancement. By the way, while we're on this subject, can you distinguish between dental advancement or dental expansion, dental alveolar expansion, and then skeletal or orthopedic expansion?
Absolutely.
And then what are we seeing here? Just
Yeah. So basically,
bring it full circle.
so 3 types of expansion. So one is dental expansion. Dental expansion is very simple to understand. It's just the teeth moving. So no part of the bone at all is moving. It's just the teeth. Okay. So if you put, maybe braces on the teeth or aligners or something, and you put a force that broadens them out or tips them forward, then the teeth themselves will move within the bone. Okay. That's one type of expansion. Now I'm going to go to the opposite end and talk to you about orthopedic expansion, and then we'll talk about the one in the middle, because that one in the middle is the one that most people have the hardest time understanding.
Totally.
So orthopedic expansion means moving of the bones, all right? That means that, ignore the teeth. If you just looked at the bones, you will see, changes in the bones. And this skeleton's held together by magnets, so you might see a lot of changes. But basically, you're going to see the actual bones move, all right? The whole entire bone. So the green part, okay, that's moving. That's orthopedic expansion. That's what most people want when they are looking at resolving airway issues, or when they're looking at correcting big bite discrepancies where their teeth aren't fitting together at all. That's what most people want, because if the bones move, well, now the teeth don't have to move. They can just stay in the bone and they can fit better. Okay, so that's orthopedic expansion. The last one is dentoalveolar bending, which is a form of quote unquote skeletal expansion, if you get technical, because it is something that's happening or changing to the bone. Basically, the bone around the roots of the teeth can mold or bend. And if it does bend, it results in teeth being able to be in locations that they otherwise wouldn't be able to. So this is a great example in this case here. Like if you just look at the before and the progress photo here, if this bone wouldn't have adapted or moved in some way, this tooth would literally be probably falling out of her mouth, okay? So because the bone around the teeth adapts, it allows this bending force to happen here, just in the area of the bone surrounding the teeth here, that does allow for more movement. So and this is where so many people get confused, because they're like, oh, well, if I do an ALF, or if I do an AGA, or if I do, whatever, you might get some dentoalveolar bending, which technically, as James Nestor pointed out in his book, is a quote unquote skeletal change. But that is vastly different from an orthopedic skeletal change. And this is vastly more limited than what you can do when you're actually moving the bones, whether it's orthodontic surgery or MARPE or whatever else it might be that you're doing.
Right. Thank you for distinguishing that. And another thing I'd like you to talk about in this case is the head posture in the scan, in the before and after, and how that's affecting the apparent change in the airway.
Absolutely. So these images are superimposed on what we call the anterior cranial base, which is all these stable structures here. Okay, so this is also the most stable structure to superimpose on in kids, and so that's where that came from. But if their head position is different, then you'll see that from before or after or progress, depending on where their head is, you'll see the vertebrae change, because that's literally changing as you move your head forward or backward. In the initial image here, you can see that the head posture was more forward, and then in this progress photo, the head posture was more back. So this airway appears to be much more narrow in this image than it was in this image. And so we're thinking, oh my God, did we harm the patient's airway by doing this MARPE, even though everything came forward? No, this is just a function of where the patient's head was at the time, we did this.
And as you explained in your course, this is one reason why this slice of the airway can't be used really as, number one, a great diagnostic for sleep disordered breathing, but also not a great metric for how a treatment has affected the airway, just because this slice is so dependent on head posture.
That's correct. Yes.
So then and then in the course you mentioned the slice can play a role in helping potentially diagnose sleep disordered breathing, but just as one metric among many.
Yeah, it's a screening tool, not a diagnostic tool, right? So if we're just screening and we're looking, well, if that's a huge measurement and you can see their heads back, well, that's, less likely to have any type of airway problem than if their head's all the way forward and it's still a small number. So you use it as a type of screening tool to gauge, how likely is it that this patient is having sleep problems? we're always going to pair that with, a questionnaire, asking them the questions about, are they having signs and symptoms of sleep disorder breathing? So it's basically just one of the tools. When Airway first came out, people got so excited about this volumetric airway analysis, but really it doesn't tell you much of anything except for, what it looked like at one point or the other and where their head position was.
Right.
So, I mean, if you were to control exactly, if you had a way to get the patient and the machine in the exact location, could it detect changes in the airway volume to some extent? Yes, it could, but it's also dependent on other things like, was there any sort of swelling or inflammation that day? Did they have allergies? Did they swallow at the exact moment? Where was their tongue posture?
Wow.
So there's so many things that are affecting what this reading of the airway is going to be. We look at it, we glance at it, we look for obstructions, we look at the tonsils, we look at the adenoids. Where are those? Do those look obstructive? But we're not diagnosing anything off of a volumetric airway analysis.
Right.
And they're standing up. They're not laying down like they would when they sleep.
Right. And I think in a time past, they did have scanners where you would lie down.
Right.
But then for some reason, the field drifted away from that, even though those may be better for diagnosing.
I think it's just honestly a workflow thing, and
Yeah.
just you can get in and out faster, standing up, it's just easier.
Yeah, that might be a bigger machine to take up more real estate inside of a smaller office.
Right.
Okay, you had some other cases pulled aside that we discussed that we wanted to put in the video.
Let's take a look at one of the questions I know I get a lot is about age. Like, can you expand if you're, older versus younger? Like, how does that work?
Yeah.
Okay. So this patient was in her 70s.
Wow, look at that result.
So
That's really
and again,
nice.
like, I can show you this and I can tell you whatever I want about that and you might believe it. I can tell you I used an FME, I can tell you I used a 4TAD MSE, I can tell you I used a custom MARPE, but this is only a small part of the equation. And so in this case, I actually did use an osteotomy and a 4TAD MSE. And in hindsight, again, I would have erred on the side of having more anchorage, not less anchorage. So I probably would have used at a minimum a 6TAD MSE and probably a 6TAD or more custom MARPE to ensure that the anchorage was sufficient. But let's look at what actually happened with her. And we'll see here, this is again that jaw view. All right. So this shows us what expansion that we got. You can see here that we got a little bit more expansion on the left side than we did on the right side. And you can also see that the posterior expansion in this patient is not quite as significant as it was in the patient that we just saw. You can see here that the resistance in this area back here, whether it's the pterygoid plates, which you can see here, there's one in the other, there's one in the other, or resistance near the back of the palatine bone, it resulted in not as much posterior expansion as it did in anterior expansion in this case. So now we're looking here. So now we can see that same view. And what's interesting is we can reinforce a couple things that we talked about before. You can see here on the right side, that condyle did move forward more or relax forward or whatever you want to call it, more on the right side than it did on the left side here. And you can see, again, the changes all the way up to the level of the cheekbones here. And you can see the nasal passages open as that expansion occurs, okay? So this gives us an idea of what actually happened with that expansion. So now the question is, like, how much did those jaws move forward or not move forward, right? There's no way to know unless we actually look at it. So this here is the superimposition showing the vertical and the AP changes that occurred. So you can see here, again, we're fixed in on the skeletal base here. So nothing's moving in the top skull, that's staying the same. And you can see here that the teeth and the jaw, there really wasn't a lot of forward movement. We had a little bit of downward movement here. We had the lower jaw relax and come forward, but we really didn't see a big change like we saw in that first case with the entire maxillary complex coming down and forward.
The gentleman.
That's correct, yeah. Now, was that because we used the 4TAD MSE? Did our anchorage give out at some point? Did we get more expansion and then it kind of like dropped back a little bit? Like, those are the questions that, we're still trying to work out. At the end of the day, we want the most predictable expander possible and be able to know in advance what type of expansion we're going to get and ideally be able to adjust or modify that as we go.
Yeah, and this uncertainty as to what's really going to happen with the interiorization of the maxilla with MARPE, the uncertainty around that is an example of why they say that with orthodontics, you have to treatment plan anew with every appointment, right? You can't really plot exactly where you're going to end up at the initial consult.
You plan as best as you possibly can, and then absolutely you need the tools to be able to adjust as you go along.
Right, right. And one potential future development in this space could be, as you mentioned yesterday, AI interpretation of radiographs to help anticipate how the skeleton might respond to some of these forces.
I think that's the direction it's going. Not only could it give us a better prediction, I think, once they work out what the algorithms are, right? If they find a way to standardize the imaging and they find a way to analyze the sutures and give us some sort of objective measure, well, now not only do we know where the resistance is, but now we also know where the best areas of bone are. So we can say, hey, we have this many grams or ounces of resistance at the maxillary suture. So if you do an osteotomy with this portion, it'll alleviate that. And then we have this much resistance here, and we have this much resistance at the pterygoid plates. And so this is the amount of force that you need. And this is the direction that that force needs to go in order to get perfectly symmetrical expansion. So I think within my lifetime, that will be a reality. And that would be amazing. Because then essentially AI is solving the hardest problem to solve, and it's what's Facegenix is trying to solve it. Us as practitioners are all trying to solve it. Is how can we predictably get the jaws to go exactly where we want them to go when we're expanding? We've got it dialed into the point where it's like we can get them pretty darn good, right? To the point where your average layperson isn't going to notice if one side expanded a little bit more than the other, or if it was slightly asymmetric. We're going to use TADs to overcome that. So we can get it pretty close, but with that type of information, theoretically we could get it exactly on.
Right.
That would be the goal. I mean, we know it's never going to be exact, but that's the direction. Like if I were starting a company and looking into this, like I would be looking into what AI CBCT volume data, like something that can read that and do it consistently and be able to spit out meaningful numbers and give you an actual force to put on the jaws to make what you want to happen.
Right, and probably the first step in feeding that AI the data that it needs to determine that stuff is to take as many radiographs as we can get from prior MARPE treatments that show, this bone responded this way to this expander that was spreading in this direction.
Absolutely.
And maybe, that's the first step toward achieving that.
Absolutely. And it's difficult data to get, right? I mean, because not only do you need the imaging itself, but you need all of the information about the anchorage. You need the type of TADs that were used. Were they seated down completely? Was it bi-cortical? So there's a lot that goes into it.
Wow, totally.
But I mean, it certainly could be done. It's within the realm of possibility. And if it were done, we would all benefit from it.
Totally. All right, what are we looking at here?
Okay, so this is probably the case that made me the biggest believer in having a screw be able to significantly change the way that the jaws move.
In other words, guided asymmetry.
Correct.
Essentially.
That's correct. So this
using asymmetry to your advantage.
Correct, or in this case, disadvantage. So
Right,
so
exactly.
We'll go through it. So this was a case that was sent to me by a doc who was wondering what's happening with this case. Like it's not doing what I thought it would do, and I'm not entirely sure what's going on. And so just looking at this, when I first looked at this image, I was pretty sure. I'm like, hey, you know what? There is probably a fracture of the maxillofrontal suture here, and this side here is down and forward. Because this image is very indicative of what we would typically see with that complication. But the other thing I was thinking is this is not, a 40-year-old male. I mean, he's still a teenager. And so I'm like, okay, well.
Why does that matter?
Yeah, because the growth plates may not be complete at that point. And so and the bone bends a lot easier. So younger bones and certainly bones that are still growing bend a whole lot easier. So it's a lot less likely to have a fracture at a suture that you don't want it in a growing patient, even if they're, on the tail end of their growth, than it would be on a 50 or 60 or something like that.
So younger patients tend to get sutural bends, older patients tend to get sutural breaks.
I wouldn't say they tend to, but if the force is too high, yes, they're more likely to get a break than would a younger patient, and certainly than a growing patient.
Got it.
So I'm thinking this is pretty young. I mean, in fact, this would have been maybe one of the youngest patients I'd ever seen with that complication, if that in fact were what it was. And so I said, I'm looking at the photos, but can you send me the actual volumes? Can you send me the radiographs so I can put them on top of each other and we can look at what actually happened?
You really put a lot of emphasis on superimpositions of the radiographs. That's
only
one thing I picked up from your course.
It's the only thing that tells you what exactly, otherwise we're just guessing. Yeah. So, we can guess all we want, and there's, one of the admitted downfalls of our profession is that so many well-known, prominent orthodontists did a lot of lecturing and presenting, and they would basically present information that they thought was right, but we never had the actual data to back that up. And so many of the philosophies that are still around today are based off of incomplete data. So at this point, we have the ability to get the data. So there's not really an excuse. It's like, take images of your patients before, take them after, and understand what you're doing. Yeah. I'm not saying that you can't do good treatment without it, although I think it's very difficult, but certainly you can't tell everybody else what you did unless you know what you did.
Right, especially because due to human psychology, people are more likely to interpret something the way they want to interpret it.
That's correct.
Yeah, so you need objective data.
That's correct. So, I saw this, I'm thinking, oh goodness, this left side of the jaw is, going down and forward. This is not good. You need to unturn it, that kind of thing. I'm like, send me the images. Let's look deeper and see what's going on, okay? So this was the pano. You can see like quite a large diastema, like very, very large. Typically, I'm not expanding at a rate that would ever create a diastema that large. And so we can see that.
Wait, what do you mean by that? You expand at a slower rate, and how does expanding slower prevent diastema formation?
Yeah. So the same thing we explained about the elastic nature of those teeth. The slower you expand, those bungee cords between the teeth are going to start moving those teeth together. Wow. And or if you have them in braces or you have them in aligners, you're actively using force to help close those spaces down. So these images, I want to say it was less than 2 months apart from the initial image to that much expansion. So that is a lot of turns in a short amount of time.
Got it.
Okay? If he were 30, 40 years old, almost surely something would have broken. Like almost surely, okay? So, because again, the bone can't bend that fast. So this is what that looked like on a pano view. So let's look here, and I want to start with this view first. So this shows us the actual expansion that occurred over that 2-month period. So you can see there in the middle, that's the white part here. This is the actual MARPE appliance, okay? So you can see here that primarily within those 2 months, it's the bone that's moving. You can see the entire nasal floor widen. You can see all the way up here to the level of the zygoma is pushing outward. All right, so that's a lot of skeletal change in a small amount of time. Okay, so we know that the bones are moving. So let's take a look. I'm going to actually go to this one first. Okay, so now what you're looking at, I know this is a weird view, so let me explain what you're looking at. We're back to the view where you're looking straight up like this. So the nose would be at the top of the screen. So this side over here is his right side, and this side over here is his left side. So when you look at this, Ron, what side do you feel like went forward more?
This side.
Yes, right? So that's the patient's right side.
That's the right side.
Yeah. So again, it's very easy to see when you stack the x-rays on top of each other. So it looks like the patient's right side has gone forward more than the left side, and that's exactly what happened. But when I look here, why is this right side going forward more and the left side's going down more? Typically, when you have a fracture, the same side goes down and forward. For all those reasons we mentioned about the resistance, you release the resistance, it just takes off. It goes down and forward. So I've got one side going down and the other side going forward. Is not adding up.
Right.
Like it's not explained by the typical complication that can happen.
Right, not adding up to a frontomaxillary suture break.
That's correct. And so let's look here. Now this is the reason that this happened, in my opinion. So these lines that you're seeing here, this back line is a skeletal landmark. You can see that it's lined up in the external auditory meatus, basically the ear canal. So this is kind of the direction from ear to ear.
That's the reference point.
That's the reference plane, okay? And again, we're looking up at the jaw, so the nose is up here. This is the right side, this is the left side. This here is the screw. The screw is what applies force to the framework, right? The framework that holds the TADs, the FME, the anchor bodies, whatever you want to call it. The screw is what applies force to the part that's connected to the jaw. You can see the angulation of this screw here. It was placed in such a way that the left side of the screw was more posterior and the right side of the screw was more anterior. And that's exactly how we saw that jaw move. We saw the right side of the jaw move more forward And the left side of the jaw, it still moved forward, but less forward than the right side. And this is where the screw was. So now what we're going to do is we're going to change views and we're going to look from the other dimension. When we talked about having this lined up in all three dimensions, this is what we mean. So let's go here now. And that actually shows, well, let me jump to that afterwards.
That's a really cool image.
Yeah, we'll go to that afterwards. Let's go to this one first, all right? So now you can see here from this view, here's our orbital line reference. So this is the orbits here, roughly lined up. Here's our occlusal plane, roughly lined up. And here is that screw. You can see that from a left to right standpoint, it's also not aligned. So basically, because the force provider, the screw itself, was putting force on those, we'll call them anchor bodies, basically the custom MARPE framework, in a way that was not parallel, the bones moved in a way that was not parallel.
Right.
And so this really boils down to an error on the lab's part in where they put that screw. And you know, to give all credit, this was not a Partners Dental Studio case, okay? But, and I only say that because they're the most well-known for these custom MARPE, so I don't want people to make false assumptions, okay?
Correct. They're like the only lab that is associated with the manufacturer of these devices.
Right.
But this was not them.
That's correct. And there are other labs around the world that are doing custom MARPEs just like this, and there are other labs within the States that are developing the technology to do just that. So, but just to qualify that.
Okay, so then what do we make of this case?
So basically what he had to do was, and thankfully since this patient was growing, is they just unturn. So they undid the asymmetry as quickly as they could. And again, those images were only 2 months apart. So we didn't have a lot of time for bone to fill in and harden and for, you know, to make that a difficult process.
Right.
So once the asymmetry was corrected that way, then a new appliance is fabricated with the correct force vector so that you can continue the expansion in a normal way.
Yeah. But are there bigger overarching lessons we can glean from this case about maybe can we angle our jack screw in a certain appliance a certain way to maybe guide our own type of asymmetry, maybe in a patient that has an existing asymmetry? Or if we have an asymmetric expansion, maybe we can put in a second expander to go the opposite way or to asymmetrically expand the other side to get it to match?
That's the way I think that this is going. I think that solving this equation and being able to not only expand the jaws, but to move the jaws any direction we need them to. I mean, and I say that loosely. I mean, we're not going to be able to move them any direction we need them to, but to be able to have control of the forces that are placed on the jaw in a way that's actually meaningful, to where we can affect correction of cant, you know, anterior, posterior discrepancies, whatever it might be. You know, maybe it is a 2-screw, a 4-screw. I mean, like, if we can adjust the screws in different areas, well, that provides a lot more ways that we can provide force. You do more in the back than the front. Again, it becomes complicated. You know, patients are going to have it in their mouth. I don't know what the answer is. But that's the question we need to be asking, and that's the direction, in my opinion, that we need to be going. And out of all the things that FaceGenix offers, that, in my opinion, is the number one potential benefit.
Wow.
Is helping to solve that problem.
Wow. Well, it's noontime. On that note, why don't we end on that forward-looking note and keep an open question as to how MARPE can continue to develop and improve going forward. So, Doctor, thank you so much for that incredible presentation and for your time and your energy and for all that you do to help patients and to help keep the needle moving forward in orthodontics and in skeletal expansion.
Absolutely. Yeah. And so, you mentioned a couple times the MARPE course that you'd watched that I had sent you. So I wanted to clarify just so your audience knows what it is.
Yeah.
So it is a course that's designed for doctors. So for me personally, it was very difficult to become educated on such a newer topic that not many people knew about. And so it was very difficult to get that education. You had to fly different places and attend different courses, multiple courses, before you felt comfortable enough to actually do these procedures. So my goal with this course was to help get information out there in a way that docs on a more global scale can access it. Because until we start having these conversations as practitioners, and really as a majority of practitioners, it's going to be very difficult to continue to move this forward, and it's going to be, a very slow pace. So the more orthodontist practitioners that are involved in learning about what's happening with these cases, the faster that the progression is going to happen and the better the results will end up being. So that's what the course is. It's essentially a continuing education course designed for dental professionals. Now, if you're a patient and you're just wondering and you want to learn all about it, that's fine. I mean, you could take it, but really it's not designed for patients. It's designed to educate orthodontic professionals.
I took the course, by the way, and I loved it. Well, I think patients will learn a lot from it. I mean, there's a lot in there about how to actually install these appliances, but and maybe that part's not that interesting to patients, but I would say most of it is relevant to my audience.
Well, certainly to you specifically, you know a lot more about MARPEs than most dental professionals do. So, I mean, you're kind of an outlier there, but again, you educate your audience well also. And so that can be hopefully something that's beneficial to them. I did start a YouTube channel as well, and it's not specifically for MARPE. It's kind of all things orthodontics, and there is more general public type orthodontic information on that. So that's called Vegas Orthodoc. So they can look that up, and we're continuing to post videos. A lot of that is focused on preventing these type of problems so you don't need a MARPE later. Early expansion in kids, looking at how we do that and why we do that, what benefits we're seeing, specifically from an airway and health standpoint, but also just from an idealizing facial aesthetic standpoint.
Yeah, and just very quickly, early expansion in kids, I know that's a whole separate topic, but what do you mean by early? How early is early?
Yeah, so I mean, early for me is really anything 7 or younger.
Okay.
So
right.
yeah, I mean, because once you get to, the later mixed dentition, your anchorage decreases, the baby teeth are falling out, the roots aren't as good. So if you want really, really good orthopedic expansion and you need a lot of it, if you can get in, my favorite time to expand is right before the first molars come in, assuming they don't have any other problems. So typically they're, 5.5, 6. The patient's old enough to tolerate everything and they can get along well. And the roots of the baby teeth are very solid, so it provides a good anchor to the bone, and the bones move very predictably.
Why don't we take a rain check on a future discussion about early expansion, because me having one daughter now and another child on the way, this is something I want to learn more about to make sure I set my kid off on the right foot. But you, besides your course, you also have a new offering, I believe, for remote consultations with patients that might be interested in pursuing treatment with you.
That's correct. And not even necessarily patients who are interested in pursuing treatment, maybe or maybe not. It does become logistically difficult to treat patients that live far away, because in the initial parts of expansion, you do have to keep a close eye on things. And sometimes I need a patient to come in so I can physically look at it in addition to the remote monitoring that we're doing. So, but what it does do is it was designed to help patients understand all of these things as it relates to their case specifically. So are they a good candidate for MARPE? If they were to get a MARPE, how should that MARPE be designed? What are some of the red flags that they should watch out for? Are they at a high risk for asymmetry or for fracture? Basically going through their imaging, and it's not gonna be like submit your photos online and we'll talk. It's like you need an actual image, you need an x-ray, you need a 3D volume image. So that would be something that you would get from a local practitioner. They don't have to do MARPEs, but many practitioners have the 3-dimensional imaging capability. So you would obtain that wherever you are, and you would send that in along with your concerns, health questionnaire, the whole 9 yards, photos. And what I would do is go over all of that in detail and then put together a video of giving you my thoughts about your case specifically. Like, are you a good candidate for MARPE? Why or why not? Would surgery be better? Why or why not? Would I not do anything? Would you, should you do neither of those and just get the teeth to fit together? So essentially, it's just giving you one man's opinion about what might be done, knowing that that person has a little bit more experience with moving bones non-surgically than maybe some other practitioners.
Fantastic. And how can people access that offering?
So that's going to be on vegasorthodoc.com. And so they'll be able to go there and it'll all be completed. They can upload the photos there. They can do the whole correspondence. Everything will be done through that website. So it's vegasorthodoc.com.
All right. Link in the show notes to that and to your course as well. All right, Dr. Manuele, thank you so much.
Ron, thank you for having me. It's been a pleasure.
All right, absolutely.